No, when he joins, we'll have it. Uh, good evening to all. We would welcome you to the third day of the certificate course of FOGSI ICOG on labor and birthing. We had 2 days of extensive deliberations on labor, and we would like to welcome all the esteemed faculty who have joined today, the esteemed office bearers of ICOG, especially Dr. Parag, who has joined for all 3 days and has given us encouragement. I would like to welcome all the faculty as well as the conveners of the other 2 days, both Dr. Reshmi Kahar and Dr. Poonam Goyal, as well as the coordinators for all the 3 days, Dr. Umayal Murugesan, Dr. Kavita Bhatti, and Dr. Monica, who's there today with me today, as well as all the esteemed chairpersons. And a special welcome to all the delegates who have joined on both the days, made it a big success, and you all stayed with us till the end. And you were also there for the interaction which you had for half an hour yesterday. I'd like to thank all of you for joining and making this program a success, because you know that hardcore obstetrics is what is our bread and butter. Rest all is after that. And we could see that with the deliberations how important it is to everyone in the country. We had on 2 days two extensive discussions, and they were on phases of labor first by Dr. Saraswati, and then we had two stalwarts talking on interventions in latent labor and arrested labor, Dr. Poonam Shivkumar and Dr. J.M. Kannan. Then we had two futuristic topics of labor, that is AI and omics in labor, and which was well received, and that was by the TSHTI team, and they gave a great overview of the topics, as well as we knew that something new is going to come in the field and that may help us in our future. And we had beautiful talks of maternal positions in labor by Dr. Vidyadhar Bangal, and a topic on program labor by Dr. Kartikeya Bhagat. Both were well received. And then we had a very interesting panel discussion on interventions in labor by Dr. Poonam and Dr. Sneha Beer, and 4 young panelists who did extremely well. The second day we had topics which were discussion on intervention labor dystocia by Dr. Girija Wag, and Dr. Intrapartum ultrasound was done by Dr. Anupama Rao. Epidural analgesia was by Dr. Preeti Vyas. I did the topic on changes in guidelines, and Dr. Reshmi talked on MSAF and labor. And a very interesting topic of VBAC was talked about by Dr. Suma. Nomenclature in labor was done so well by Dr. Chinmayi, and that set the tone for the panel discussion on intrapartum surveillance, where lots of terminologies have changed, and we could see that so many changes have happened, and that is all what we need to update ourselves with. Today we have got great speakers, I would say, because it is an honor to have stalwarts like Dr. Hema Duvakar as well as Dr. Paley with us today. Hema madam is going to talk on P2L, the FIGO initiative. And then Dr. Manjupuri madam is going to talk about the respectful maternity care, and that entails labor care through the prism of quality, because whatever we do, if quality standards are not met, the program is the delivery even we conduct is not going to be a success. The utility of the labor care guide will be dealt with by Dr. Yashita Puja, whose team has done a great multicentric trial throughout the country on the labor care guide. And auditing in labor will be done by Dr. Suchita, who's always very thorough in her discussion. We're waiting to hear all the 4 speakers in the first session. The second session will be on oxytocin low dose was high dose, and that's by Dr. Raja Rajeshwari. She's from a small town, but she's a great academician and always prepares so well for any program. And the next will be by Dr. Pranjal, who's known to be very systematic. She's going to talk on contractions, the clinical electronic details. And then Dr. Parag Bamre from Chapaigo will be talking on Frontier Solutions remote monitoring of labor, because when you have labor happening in remote places, you can still monitor with algorithms which are being given by AI. And Chapaigo is one of the partners in the where they give us information on such technology. And then we are going to have a special talk on a special topic, that is special situations in labor, which we are facing so many times now, obesity as well as FGR. And that will be by Dr. Aruna Kumari from Rajamantri. And the much awaited talk by Dr. Paley will be on obstetric rapid response team, a must in every delivery point. And Dr. Geeta Balsarkar, professor from KM, will be talking on the panorama of near miss in labor. So all are extremely important topics. We request that all of you be with us throughout the day, And please interact with us at the end of the program because we may not have time in between for interaction. But we would request you to stay back if you want to talk with the concerned speakers. Now it's my honor to invite Dr. Parag Biniwale, the chairperson of ICOG, to address the gathering before we start the academic session.
Yeah, thank you, Charmila. Good evening. I bring greetings from ICOG, and it's indeed a pleasure to be talking to you on the third day of certificate course on labor and birthing. I acknowledge presence of Dr. Hema Devakar, who's done so much for ICOG, and she was president of FOGSI ICOG long ago. So Hema, thank you for being here, and thank you for inspiring us all these years. Charmila, I must appreciate work done by you and the entire team, the coordinators and the conveners. So labor and birthing is something which is so close to our heart because it's day in and day out we are managing women in labor and birthing. It is important for all of us to understand what is new and try and adapt it as early as possible because in fact, it is going to translate into better clinical management. And of course, we hope that all our delegates take home apt messages given by our speakers and their practices change for better. And ultimately, it is the women who come to us in labor for birthing are benefited. So best wishes for third day, and for all the delegates, please don't forget to write the post test because if you have attempted post test all 3 days and if you've scored 50% marks, you are eligible to get a certificate from ICOG. So thank you and best wishes for the program.
Thank you, Dr. Parag. And we'll also like to welcome you all to the ICOG conference, which will be there next weekend, 1st and 2nd of March. Please attend the conference. It is going to be an academic feast, which will benefit everybody. And can I have the CVs, Monica, before we start the academic session? Please share the CVs.
Can you just allow, there's another, I've logged in from my desktop. If you could make me the co-host there so that I can share my screen, ma'am.
Gauri, please make her the co-host in her other device also.
Still not allowed, ma'am.
Gauri? Now it's there, yeah. Go on to
this
your...
ICOG is doing, ma'am, I think.
Okay. Go on to Dr. Monica's CV. Please go on to Dr. Monica's CV. Please make it a slideshow. Monica's CV. It is always a great pleasure to work with Monica, who's one of the most hardworking people, I would say, in FOGSI. She's a consultant obstetrician gynecologist at Mangalya Nursing Home and Adarva Fertility Center. She's the website coordinator for AMOX 1820, youth coordinator, executive committee member of both the Public Awareness Committee and ISOPAP. Has been the treasurer of IMA. She's been the treasurer of the Solapur Obstetrics Committee, as well as a clinical secretary, the honorary secretary, executive committee member since 2014. I've worked with Monica for almost 10 years now, and I would say she's such a great help and always a good friend. May I request Monica to take over the sessions? Please introduce the chairpersons of the first session and let them introduce the first speaker, Madam Hema Devakar, ma'am.
Thank you, ma'am. Thank you so much for allowing me to coordinate the third day today. And thank you, Parag sir, for the opportunity, and Chamila madam. It has been an excellent session for all the previous 2 days. Now I take the privilege to introduce Dr. Sapna Bajaj Jain madam. She's a director at Sagar Multispeciality Hospital, Bhopal, and she has been the ex-professor at LNMC, Bhopal. We welcome you, ma'am.
Thank you.
Our next chairperson for today's session is Dr. Rakhi Singh madam. She's currently the president of Noida OBGYN Society, and she has been the past person of the FOGSI Endocrinology Committee from the year 2023. We request both of you to chair the next session, and I request you to please introduce our stalwart, Dr. Hema Devakar madam, for her first talk for the session.
Thank you, Monica, for the opportunity. And thanks to the ICOG team, Dr. Parag,
and Dr. Charmila for setting up the stage and having a lovely set of certificate courses. Dr. Hema Divakar, she is a known personality who's having a lot of knowledge and everybody is keen to hear to her. She is the past president of FOGSI in 2013 and a medical director at Divakar Specialty Hospital, senior consultant, OB-GYN and a chairman, CEO and chairman of Artists. And she's a vice chairperson for the chair for the FIGO PNCD committee 2015 till date. Over to you, Dr. Hema ma'am, for the lecture.
Thank you,
Always a
Rakhi.
treat to hear to you, ma'am.
Thank you. Ladies and gentlemen, it's said that change is a constant, but it doesn't apply to some people. Ever since I have known the evergreen Dr. Parag Binewale, for years and on, my very beloved friend, colleague, and now in the leadership position of the chair of ICOG. I'm so proud to see you in that position, Parag. Congratulations and best wishes for the wonderful work that you will continue to do beyond the positions of the chairs of different leading expertise across the country and the globe. And best wishes to you. The charming Charmila and the Monica, who is coordinating today's event, and Sapna ji and Rakhi, and all my beloved friends here. The deliberation is again on the changing times in managing labor. That's what this entire initiative is also about. And presently holding the position of Division Director of the Well Women Healthcare. How do we unlock the potential of Femtech for women's healthcare? That's what has been buzzing very, very constantly in our minds, because in the new era of technology, we feel that to reach the last mile and to do better than ever before, this should come to our rescue. And the P2L, what is this all about? It's prep to labor. That's a new terminology coined by Aiton Barnier, who hails from the USA, and he's a very, very important member of the Committee of Women at Reproductive Age under our division. And with the help of Gates Foundation, there's a action tool. This is the era of apps as well. So the FIGO technology and the role of the FIGO members, how we will reach the care to the unreached, how we will give equitable care with quality everywhere, how we will harness the local expertise, how we change the policies, how we'll strengthen the primary health care. All of these as global leaders and influencing the policy constantly, it hits our mind. And once it comes into practice, it could well be the game changer. Like how we pledged that no mother should die while giving life, and Manyata stood and is standing strong as a flagship program of FOGSI. And again, the technology and the digital era, which was enhanced by the onset of COVID, where everybody were forced to plunge into that. We saw a major shift after we skill transferred through the technology, whether it was Bihar, Tamil Nadu, Punjab, Maharashtra, right across the country. You see the shifts in the thinking and practices with some simple messages given, and every of the staff who were in the team learned it within seconds, within minutes, not rocket science, just the attention to details and the wisdom started changing the trends of how many women were covered with a single step test, how many did receive the active management of labor, how many understood that diazepam is not the choice for eclampsia management, plotting the partogram, which was like, often done as a postmortem, after the delivery process is over. Everything started shifting in a big way. And so many of our publications have proven that even though we do not do on-site as much as we would have done before, the building of capacity of frontline providers indeed has made a lot of difference. This got us thinking, if there is a neonatal assessment, every pediatrician uses the UPGAR score. 2 points for this, 2 points for that, this, that, and the other, a score of 10, and all of us can relate to what an UPGAR score of 2 by 10 means, what the UPGAR score of 10 by 10 means. So the same kind of a thought process was running in the mind of our colleague from FIGO, Eaton, who said that why can't we have a simple score for mothers, which everybody who is attending the labor will use, and considering that that landscape is quite different across the globe, can it be something which is easy, which is universal? It has some emojis like smiling if everything is okay, crying if something is serious, etc. So how can we get the frontline healthcare workers to adapt to this? So as you can see here, the APGAR score, the dry skin, skin-to-skin contact, breastfeeding, those are the actions which are uniformly taken, activity, pulse, the grimace and irritability, appearance, respiration, APGAR, APGAR. This has come into the DNA of everybody who is handling the neonates. Many papers were produced around this thought. How can we cut, paste, copy, and make it happen in the process of monitoring intrapartum patient as well? So here's several more publications, but few of which I have showcased here. And we hope also that India will be able to showcase the application of this, the implementation of this, because in FIGO, the P2L, prep to labor, is in the beta stage where the experimentation has been done, the pilot studies have been done, and India is chosen as one of the key countries to implement this in the next few months. And we are hoping that all the network of our Manyata centers will be guided in a uniform way to actually get it off the ground and showcase to the rest of the world. So what does this kind of scoring contain? So very basic, very preliminary. Every screen gets over in just less than 1 minute. The maternal condition, what's her age? Is she stable? Yes or no? Alert and responding? Yes or no? Good health? Some people have a toxic look. So just that appearance, yes or no? Pain, whether she's in labor or not. Then they'll go to the urgent module if the bleeding is a yes or no. So that's in bold. That's why. Then pale or pink, and whether there is jaundice. So all these, they will mark on the screen on the app, which is very easy to use, and also note the comorbidities, out of which the hypertensive disorders rank very high, diabetes, asthma, because when they have to give the active management, they will also be alerted when they write that, yes, she has a issue with the asthma and other conditions. And some of these, which are given here, inclusive of the COVID vaccine, the yes or no. This is the triage evaluation, the primary screening, which takes less than a minute. Then there are some 6 things to be seen. Each one has a score of 1. And if it scores 1, 1, 1, 1, then score of 6 is a normal score. Why? Because score 1, if the temperature is normal, score 1 if the respiration is in the normal range, score 1 again if the BP, if she is a normotensive, 1 if she is not anemic, and 1 if a pulse rate is recorded to be in the range of what you would expect. So if she scores 6, it's a green zone and it's normal. But anything else, temperature, either too less or too high, then it gets a score of 2. Similarly, the respiratory rate, then the BP more than 160, 110, or far lesser, 90 by 40, the hemoglobin, if she's really pale, and the tachy or bradycardia. Each one gets a score of 2, 3, etc., as it's shown here. And what to do with it, whether to give an antipyretic, oxygen, BP, anti-BP medication, IV line to be started, etc. And the urgent modules again go to the bleeding and the high BP, it'll immediately take them to the urgent modules of hypertension and bleeding. So if the score is not 6, that means all is not well. If they add on all this, which is an automated addition, one needs to be very guarded if the score is between 7 to 8. And if the machine shows a score of 8 or more, then many things are not okay and she needs to be transferred urgently. So there is no time lag, no confusion in stratifying a normalcy versus caution versus immediate transfer. And so these emojis are also very, very interesting. Urgent module of bleeding, pad counts, the clots are there or no, previous bleeding episode, previous PPH, previous transfusion, coagulation is happening or no. Urgent bleeding management, and there is an emoji shown with concern that is present there. If most of these is yes, then she will need the transfer to the higher center as early as possible. Same with the preeclampsia, eclampsia. Again, it will show, has she been treated for hypertension? Yes, no. Headache, yes, no. Chest pain, yes, no. She did not recall anything. It will just drop down as a decision-making tree, inclusive of the proteins, yes and no. So the kind of management and triaging that she does at that center, confirm the pad count, tachycardia, hypotension, both cases, she will need one access the IV line. What is the fetal heart rate showing? Whether there are already contractions, is imminent delivery is happening, and what she should do if the hemoglobin is reported less than 9. All of these points are given in a way that even in a panicky situation, she will be guided of what next. And if it's a vertex presentation, if she's almost ready to deliver, then she delivers in the same setup. Hypertension, on the other hand, has she given antihypertensives? Has she given magnesium sulfate? Again, whether it's a vertex presentation, reflexes checked, fetal heart sounds assessed, contractions there or not, whether we need to induce or augment. All of these ahead of the actual next step of deliverable, it's all recorded here. Again, if the number of weeks is more than 37, you will see that 6 is always normal. That means the next set of things beyond the temperature, respiration, pulse, vitals that we have just scored in the initial stage, we now come to fetal heart rate, whether it's vertex presentation or not, cervix is closed, or whether there's rupture of membranes and chorioamnionitis presence or absence. Each one is scored 1. Then it's a normal score. Then they wait for the instruction for spontaneous delivery or induction of labor. Whereas if there is a brady or a tachycardia with the fetal heart rate noted, if it's a breech presentation, if the cervix is effaced, dilated, and she's already in a condition which is imminently alerting you and cautioning you, if there is a foul smelling discharge, if all of these get a score more than 1, sometimes 2, sometimes 3, like how it is, but the scores will drop down automatically. She's just got to enter whatever is there, and then it also gives them a clue as to whether they resuscitate, on-site delivery, give the antibiotic, transfer, etc. So the clinical score-based management, again, a 7 to 8 score, they can remain in place and be guarded, but they have to be vigilant to manage. If it's more than 8, attempt to correct with the on-site measures and deliver, if not correctable, either C-section or transfer. This is very, very easy to use because at the end of it, if this kind of a picture appears and it shows a green icon, then she knows that there is no urgent action she needs to take. If it's a red, then reevaluate and then see why this is showing a red, whether it is something to do with the urgent action that is needed for the condition of the mother or the baby. Most often it may be bleeding or hypertension, which needs urgent attention. So the traffic signaling, that is the green being in safe zone, amber being reevaluate, inform the consultant, And if it's red, take urgent action as a primary step and try and start transferring. Same way with the decision-making point. If the bleeding is resolved, if the hypertension is controlled, on-site management is possible, again, it will start showing the green icon. If it's not resolved, then the transfer is imminent. So the preterm labor management also has some special indicators, because the gestational age of the baby less than 37, more than 37 is already indicated there. And the alerts for transfer is amazing on these kind of graphs. So the take-home messages are simple yes or no action points to keep or transfer. That's the next thing that they will know with the P2L score, scenarios that they need to address, action to be taken, and it can be done on a simple cell phone. And every screen has a emoji, because if it flashes that there is a concern, anybody who cannot even read anything there can make out that there is something that is amiss, and they have to report to somebody who is capable of taking the next level of decision. So mother and fetus are stable. What are the actions, whether they will deliver or transfer? Mother unstable, fetus stable. How to stabilize the mother and deliver. Mother is stable, fetus unstable. Deliver and transfer the newborn. Both are unstable. It's an emergency care, and what they need to do next. So the point of care equipment is also helping us a lot, because on spot hemoglobin, glucose, just like how everybody's used to doing the preg check now, that's much into use. And the teleconsultations and the remote devices, which Dr. Parag Bhamre will also be alluding to in his talk. We've come a very, very long way than being apprehensive about the use of technology. There has to be a good mix, just like the hybrid sessions that we're having now. Sometimes we love to meet each other face to face in many of the conferences. Many a times, many more things can be done on a virtual platform, saving everybody's time and energy. So all in all, we put our heads together, see what is the best approach, and in very remote areas where specialists are not available, how the lowermost level of staff can just, with the click of a button, make serious decisions whether what could be the next step. So this is to be implemented in many centers across the country, and also in 2 other parts in like Nigeria and Latin America. And then we pool together our data and make course corrections before it just is produced as a FIGO app of P2L. So this is something new that is happening, which I wanted to share, especially since few of our champions will be involved with this work moving further, to really see how effective and how useful it'll be to break the barrier between confusions to clarity, thinking to action line, and actually saving many, many more lives, both of the mother and the baby. So with that new insight into P2L, which we have over the last 6 months conducted some experimental beginnings in about 40 centers, but we want to scale it up to 400 centers. We will come back to you with more news very soon. Thank you very much.
Thank you so much, ma'am. We have learned so much from you from the past 20 years. Our paramedical staffs are all been totally enlightened, I would say, because of Manyata. And it's always an honor to have you in any program, ma'am. And extremely thankful that you spared your valuable time and gave such an important topic. I know we need to move into the future, and technology as taught by you in obstetric is something all of us need to adapt for in the future. Thank you so much, ma'am. May I request Dr. Sapna to say a few words before we go on to the next talk?
It's a very nice lecture. I think FemTech is the technology which is needed in present scenario, where, as Madam said, ki thought to action, which can be taken by even the lower staff of the obs-gynae department, and women can be shifted to higher center as and when required. So this app is going to be a wonderful utility in obs-gynae.
Thank you, Sapna.
We are
Thank
going on
you,
to the
Sapna ma'am.
second. Yeah.
Can I request Raki ma'am to please introduce our next speaker, Dr. Sucheta Kinjwadkar madam?
A slide is not being like fully shown now, Monica.
Yes, ma'am. Just a second. Yeah, is it visible
Yeah,
now?
it's
Yeah,
visible
make
now.
it
It's
a
visible.
slideshow mode.
Yes, ma'am.
The next talk would be by Dr. Suchita, and she's a lead obstetrician at Kamlesh Mother and Child Hospital, Navi Mumbai since 1992. And in public health in Manyata also, she's there as a SSR champion and the past president of Navi Mumbai Obs Gynae Society. And she has also been partnered with the Lakshya Mentor FOGSI UNICEF project, Aspiration District Facility, and a trainer for the SAFE or course. And here we have to listen to her with her beautiful lecture. Let's listen to her. Over to you, Dr. Suchita, ma'am.
Monica, stop sharing. Monica, stop sharing. Okay.
Thank you. Thank you for that introduction. Thank you for this invitation and giving me opportunity to talk. Let me just share my screen. Can I? Right now, there is no
Yes,
such
ma'am.
option of sharing screen.
No, you can share.
Ma'am, you are the co-host. You will be
Yeah.
able to share the screen, ma'am.
Yes. Yeah, I hope I'm audible as well as my screen is seen and PPT is seen.
Suchita, please make it a slideshow.
Okay. Yeah, can you all see now?
Yes, perfect, perfect.
Yeah, thank you. So actually, Dr. Chamila has given me this talk of auditing in labor when I actually said, shall I speak on Robson's? So I thought I'll just give an overview of various audits, what we can do in labor room. So why actually basically one has to do audit? Because if you want to improve, you have to measure. And if you can measure, then you can decide whether there is scope of improvement. And so making audit is really essential everywhere, but more so in labor room because we need to improve our quality of care that is offered in labor room. And audit is one such QI, that is quality improvement tool. Now we can do various audits in labor room like maternal mortality, perinatal mortality, all these numbers. So we have to submit every time to our authorities and be aware what are these figures or vital statistics, you may call it as, in our own facility or hospital. But apart from that, various other points which we can audit ourselves about our obstetric practice are like indications of induction of labor, near miss case, adverse reaction report, active management of third stage, PPH, wound infection, catheter associated UTI, low upgas, so on and so forth. Now coming specifically to C-section audit, it's really essential because C-section rates, if not us, most of the patients or the beneficiaries or mothers, they are really concerned about C-sections rates happening at various facilities. And classification system to monitor and compare C-section rates at facility level in a standardized, reliable, consistent and action-oriented manner is a must. Now here for the first time in 2001, I guess, Dr. Robson from Ireland introduced a classification or grouping system. Now in 2015, WHO has performed a study in various hospitals at various centers all across many countries, and India was one of the countries. And WHO has renamed this particular Robson's classification as grouping in 10 or 10 group classification system, and it proposed the Robson classification system as a global standard for assessing, monitoring and comparing C-section rates within various healthcare facilities over time and also between many facilities amongst themselves. Now, basically this classification is done on 5 variables of all women Either they can be, these variables are, they can be nulliparous or multiparous. Number of feta, I mean, it can be singleton fetus or it can be multifetal pregnancy. Fetal presentation can be different, like breech, transverse lie, or cephalic. Gestational age, whether it's preterm or full term, and then onset of labor, whether this particular labor was a spontaneous onset or induced or pre-labor C-section was done. So these are 5 variables, and with various permutation and combinations and elimination, these 10 groups are formed. Every woman who has delivered needs to be classified, be it a vaginal birth, be it a assisted vaginal delivery, or it can be even C-section. Now, which are these 10 groups of modified Robson's classification? Group 1 and Group 2. Group 1 is basically all nulliparous women with singleton pregnancy, cephalic presentation, more than 37 weeks. So term cephalic singleton pregnancy, primigravida, and onset of labor, it will be Group 1 if it is spontaneous labor, and if it's induced or pre-labor, then it will be Group 2. Group 3 and 4 are multigravida patients or multipara patient. I mean, they have at least delivered or delivered one pregnancy, whether it's a live or stillbirth prior. So these are 3 and 4 are multiparous patient or more than one para. Number of fetus, again, single, cephalic, and term, that is more than 37 weeks. If its onset of labor is spontaneous labor, it will be Group 3. And as the picture shows, if it's an induced labor or pre-labor cesarean, it will be Group 4. So 1, 2, 3, 4, these are commonest amongst our patient population. Group 5 are all multiparous patients who have at least 1 or 2 previous cesarean sections, operative birth. Now this can be a single, this has to be a single pregnancy, it's not twin pregnancy. Fetal presentation should be cephalic, gestational age more than 37 weeks. 6 and 7, 6 are all primigravidas, and Group 7 is multipara or the paras patient, but the presentation is breech. Gestational age can be any, and it has to be a singleton pregnancy. 8 are multifetal pregnancy. As you can see in the picture, there are 2 babies here. So all multiple pregnancies, that is plural pregnancy or twins, triplets, will come in Group 8 and with any kind of presentation at any gestational age. Group 9 is transverse lie. It should be a single baby and of any gestational age. Group 10, all women, whether nulli or multiparous, singleton baby, cephalic, but important here is gestational age less than 37. So is it really important to, keep a watch on, how to actually classify. So WHO has guided us that we need to eliminate it one by one. So always start here, whether this particular patient entering in labor room, is she a twin pregnancy? If yes, she will be in Group 8. If not, it's singleton pregnancy, then ask next question. Is this a transverse or oblique lie? If yes, she becomes Group 9. If no, move ahead. Now, is this baby breech? Yes. So if baby is breech and she's priming, she'll be Group 6. If it's multi, she'll become Group 7. But no, if it's not breech, then move ahead next. Now ask whether this gestational age is less than 37 or it has crossed 37. If less, yes, then it becomes Group 10. If no, then move ahead and ask next question. Does this lady has previous C-section? If yes, then she becomes Group 5. So, given a patient is given or the mother is in labor room at that onset of labor or when she's getting admitted, one has to eliminate it in that manner. So first twins, then transverse lie, then breech, then preterm, and then previous scissor. When none of these patients are there, none of these conditions are there, then she can be either Group 1 or 2, 3 or 4. So if she's multi, she comes to this side of the grouping, that is, if she's multigravida with spontaneous pain, she will be group 3. If she's multigravida with induced, she'll be 4A. And if it's a pre-labor C-section, it will be 4B. Similarly, after ruling out all these 8, 9, 6, 7, 10, 5, if we come to know that she is primary, term, cephalic, and spontaneous labor, she becomes group A. If she is induced, then 2A, and if it's pre-labor C-section, she becomes 2B. Now, it's really important that we need to keep in mind that C-section rates that are mentioned in all these WHO manuals have not been validated against outcomes and should not be taken as recommendation, because many people who actually don't want to categorize or analyze or audit dropsons always say that this is not indication based audit. Why? Let me explain. Now, in general, these are 8, 9, group 8, group 9, 6, 7, 10, and 5 population. And can you see these figures? They are just, 2% of total mothers belong to group 8. Group 8, that is twin pregnancy. 1% transverse lie. And here, the box below, it's written C-section rate. So, C-section rate, C-section for a transverse lie, probably it's a at any viable gestation will be a C-section. So 100% C-section rate in group 9 is acceptable. Now, in general, breech babies, not more than 3 to 4% of total population. Preterm, not more than 5% of total population are preterm. Not more than 10 to 15% population will be people with the mothers with previous C-section. And C-section rate in group 5 will be 50 to 60%. Maximum population is group 1 and 2 and group 3 and 4. Now, spontaneously coming patients, a primary gravida, single cephalic term pregnancy, primary gravida, then acceptable C-section rate is 10%. If it's induced labor, then probably 20 to 35%. Similarly, in group 3, if they are coming with spontaneous labor, the possibility of, the rate, C-section rate for this group 3 will be less than 3%. Whereas this is a big population, 3 and 4. So this is a major population and we are worried, or rather we want to reduce C-sections in this primary C-sections in these two groups. Which two groups? C2, 2A and 4. 2 and 4 we want to reduce our C-section rates. Now, if we want to work on our C-section rates after doing audit, we need to have certain definitions why we are inducing, because group 2 and group 4 are both induction of labor. So indications of labor, especially if we are doing it earlier than 39 weeks, is there a clear indication for induction of labor? So we have to have our indications ready. We need to define when we are going to call it as a failed induction and then going to go for C-section. What are our delays in first and second stage? What is when we are going to say that it's failure of progress? So all these needs to be defined in our labor room protocol. Now, within these pain groups, if we actually do some audits of incidence of PPH, a neonatal outcome, morbidity, active management of third stage, whether the companion present or not, and respectful care. So if we do these particular audits, we come to know that this is one study in which some audit was done. And the amazing thing is the PPH rate was higher in term cephalic singleton pregnancy birth by pre-labor C-section than in spontaneous or induced labor, both for nulliparous and multiparous. So see, doing audit, we realize so many things. Other many C-section audits are done, like how many incidents of night C-sections, depending on the urgency of C-section, VBACs done or not. So mostly these are again for our own hospital internal policies. So while doing internal audits for labor room, I think we need to define audit points, set data collection system, analyze periodically, and then decide and go for interventions. And that's all about I want to say about for the internal audits or the labor room audits. Thank you so much.
Thank you, Suchita. As always, very, very lucid, very clear, very precise. Thank you so much. There are some questions in the chat box. Please answer them in the chat box only, because we are running a little late.
Okay.
Okay. Thank you so much.
Yes.
Was indeed a very
Can I
lucid, and
request?
it is required also to audit the
Yeah,
cases.
Raki, we are not having time for interaction now. So anything in the chat box can be put and answered. Otherwise, at the end of 7 o'clock.
Yeah.
The third speaker
Can
will
I
be Dr.
request, ma'am?
Dr. Yashita will be the third speaker.
Yes, ma'am.
Manju madam, you want to do now?
I am okay both ways, anytime.
Okay. But okay, Dr. Yashita started all of this.
Ma'am, I
Raki-
had to actually show her CV slide, but
Madam, you show your, you can introduce now, Raki. Madam's this thing is there. Introduce your own.
Dr. Ishita, she is the professor and head of the department at FOGSI College at Jawaharlal Institute of Medical College at Belagavi. Over to you, madam. We're going to hear from you the utility of labor and care guide.
Yashita ma'am, please make it a slideshow.
slideshow. Slideshow. Ma'am, there's a button on the extreme right corner for yes.
Yes, it's clear.
Now it's perfect, ma'am. The previous one.
Previous one.
Slideshow.
Yes, ma'am. On the same button. Can you please click on it, ma'am?
Yeah, is it okay?
No, not yet, ma'am.
Not yet, ma'am.
Slideshow.
Please click on the slideshow button, madam. It will go into slideshow.
Is it okay?
Yeah.
Yes, ma'am. Yes, ma'am. Clear. Yeah.
Clear, ma'am.
At the outset, I would like to thank Charmila Madam for having given me an opportunity to share our experience on the labor care guide. So today I'll be talking about the utility of the labor care guide. I bring greetings from Jawaharlal Nehru Medical College and KLE Hospital, Belagavi. As all of us know, 2.8 million maternal deaths are there annually, mainly in low and middle income countries, and 2.4 million neonatal deaths and 1.9 million stillbirths each year. And 45% of these deaths occur mainly during labor, birth, or within the first 24 hours postpartum. So quality care during labor and birth is very crucial to reduce the maternal and newborn mortality. The C-section rates are rising worldwide. Oh, I'm sorry. Here's my presentation. I'm sorry, just give me 2 seconds. Is my screen seen?
Yes,
Are you
ma'am.
able to see, madam? Yeah.
Yes, ma'am.
Seen.
I'm so sorry about that.
No
The
problem.
C-section rates are increasing worldwide, driven mainly by unnecessary C-section use. And it is expected that 38 million women will undergo C-sections annually by 2030. That is almost 28.5% of the global births. And C-section rate increased by 19 percentage points from 1990 to 2018, mostly without any clear medical indication for a C-section. ये next में जा रहा क्या हो गया?
Madam, you click on the slide and then you put the button, it will move.
I'm sorry. Yeah. So actually WHO in the 1994 trial, it said that prospective partograph use with intense provider training optimized the use of intrapartum interventions and improved maternal and newborn care outcomes. And in 2018, based on
56 evidence-based recommendations, WHO came up with a revised definition of active labor. It went up to 5 centimeters dilatation and removal of the alert and action lines. And then in 2020, the WHO came up with a labor care guide, which aims at evidence-based, respectful, and women-centered care. And currently, WHO recommends global LCG implementation to reduce the unnecessary interventions and to improve care. So the next generation partograph, I think it's already discussed yesterday. I'll not go into the details of that. It's a revised version of the existing simplified partograph, which ensures that the full package of WHO intrapartum care recommendations are included in the LCG, including mainly the supportive care interventions during labor, updates in the section for monitoring cervical changes over time. Now, this is a major change in the labor care guide, and removing the specific thresholds relating to rate of cervical change, such as the alert and the action line. So this is the latest WHO labor care guide. The most important thing is we can see alerts here. So this can be plotted even by a nurse, where we know what is the alert and then we can take action accordingly. So just want to share the differences between the WHO simplified partograph and the WHO labor care guide. As I already said, there is a shift to 5 centimeters of cervical dilatation, and there is this removal of 1 centimeter per hour alert and action line. So all of us are so used to it, supposing a patient is in labor at 4 centimeters, we expect her to deliver within next 6 hours. So that cutoff has taken off based on evidence. And so evidence-based time limits are introduced at each centimeter of cervical dilatation. And in the simplified partograph, the second stage was not so intensely monitored, where here there is an intensified monitoring in the second stage of labor. And there's an explicit record of labor companionship, pain relief, oral fluid intake, and posture. And it requires deviations to be highlighted. Supposing we are starting oxytocin, we need to mention in the labor care guide as to why are we doing it, and the corresponding response to be recorded by the provider. So initially we did this way back in 2020 itself regarding the usability, acceptability, and feasibility of the WHO labor care guide, a mixed methods multi-country evaluation. It was just a pilot study with 136 women, where we found that the acceptability rate by the providers was quite high, around 67%. And then we did this effects of the WHO care guide on C-section in India. It was a pragmatic stepped wedge cluster randomized pilot trial. This was the first trial done with the WHO labor care guide. So the main objective was to develop and optimize a strategy for implementing the labor care guide, because at that point of time it was not into use, and to evaluate the implementation of the labor care guide strategy compared with the usual care. So basically it had 2 phases, a formative phase where to understand the current intrapartum care policies and practices in the various study hospitals, to identify potential factors that may affect adoption of the LCG implementation strategy in study hospitals, and to optimize the relevant intrapartum care policies and practices in study hospital. And in the trial phase, the main primary objective was to evaluate the effect of the LCG implementation strategy on C-section rate, as Dr. Suchita mentioned, among women in Robson's Group 1. Group 1 is singleton pregnancy, nulliparous women in spontaneous labor. Because what we are seeing is, if we reduce the primary C-section rate, maybe we'll be able to reduce the C-section rates also, because whenever we do an audit of the C-section, we do find that more than at least 50% of the cases are because of repeat C-section. And the secondary objectives were to evaluate the effect of the LCG implementation strategy on women's health and process of care outcomes and women's experiences of care, and also to conduct a process evaluation on the implementation of the labor care guide strategy with a provider survey and in-depth interview of the care providers. So this was the hypothesis. We expected the WHO labor care guide to reduce the intrapartum C-section rates, because main things were removal of the 1 centimeter per hour, updated definitions of the duration of first and second stage. Now, second stage is 3 hours in a primary and 2 hours in a multi, introduction of labor companion, CTG to be taken completely off. So introduction of intermittent auscultation and positioning during labor, allow the woman to adopt position of her comfort, and provision of pain relief, and definitely respectful maternity care. So this was the hypothesis. So this was a pragmatic stepped wedge cluster randomized pilot trial done. This was done during COVID from 1st July 2021 to 15 July 2022. So it was a 6 months guided by the COMBI model of behavior change. COMBI model is nothing but we try to find out what are the barriers for implementation of the labor care guide, and then we formulated strategies to implement the labor care guide. So this study was done in 4 public maternal hospitals in Karnataka at all levels. So the Taluka Hospital at Gokak, Women and Child Hospital Davangere attached to a medical college, Gadag Institute of Medical Sciences Gadag again attached to a medical college, and Vijayanagara Institute of Medical Sciences Ballari attached to another medical college. So this was a stepped wedge randomized trial. By stepped wedge means initially all the hospitals were in the control phase. So initially they were implementing the simplified partograph. Then after 2 months, each one of them were randomized to the intervention group after 15 days time given for transition, where we did the training of the concerned hospital. So after 2 months, the first hospital was randomized, and then after 4 months, the second, similarly, the third and the fourth. By this randomization, each hospital had a chance to be a part of the study. Otherwise, only 2 had to be control and 2 had to be intervention. And also it removed the bias. So the sample size was based on hospitals which had an average birth of more than 24,000 births per year pre-trial, and the overall C-section rate was 44%, and C-section in the Robson's group 1 was also more than or equal to 40%. So this was one important thing which we developed during the training of this labor care guide. We made them something like a e-board, where they could, it was enlarged. It was very clear. All the sections were very clear, because when you're plotting the labor care guide, it's a very small piece of paper where really you don't even have space to enter. So we made this for training, and we had kept this in the labor room. So at any point of time, if anybody had a problem, they could go back and look into this. So general characteristics, the mean age was 23 years, and majority of the population were without C-section. Multipara formed 55.1% and 55.3% in the intervention and the control. And multiparous women were the maximum number of women, 51 and 52 in the intervention and the trial group. So the main primary outcome which we saw was reduction in the C-section in the Robson's group 1. So the incidence of C-section in the Robson's group 1 was 39.7%, and in the control, that is with the simplified partograph, was 45.2%. However, it was not statistically significant. So we also looked into the maternal process of care outcomes, where we found that augmentation with oxytocin during labor, definitely there was a reduction in this. In the intervention group, it was 9.3%, and in the control, it was 27.3%. However, we did not see any reduction in any of the others, like the artificial rupture of membranes, episiotomy, operative vaginal birth, days from admission to childbirth, and childbirth to discharge. We also looked into the maternal secondary outcomes. There was no clinical significance in the occurrence of 3rd or 4th degree tears, postpartum hemorrhage requiring intervention, or suspected or confirmed maternal infection. We also looked into the fetal and the neonatal secondary outcomes. Again, there was no difference found in the rates of stillbirth, antepartum and intrapartum stillbirths, Apgar score of less than 7 at 5 minutes, bag and mask ventilation of newborn, mechanical ventilation of newborn. And also prolonged admission in NICU, composite neonatal morbidity outcome, neonatal death and perinatal death. There was no significance in the outcomes in the intervention and the control period for all of these, except for fall in the reduction rate of C-section by 5% and reduction in the augmentation with oxytocin. We also did a postpartum survey of the woman for her satisfaction of the labor care process. And a total of 1,438 women in the control group and 1,277 women in the intervention group consented and completed the postpartum survey. And women reported being offered pain relief. The incidence was less here. This was because of the crowded labor rooms where pain relief could not be offered. and the birth positioning also was not offered. But however, 99%, majority of them were satisfied with their labor experience and birth in both the groups. So the results of this study, 5.5% absolute reduction in C-section rates among women in Robson's group 1 after introduction of the LCG strategy, and with 18% reduction in the labor augmentation using oxytocin. Maternal, fetal, and newborn health outcomes, it did not reveal any clear differences. And however, gaps persisted in implementing the supportive care practices, mainly pain relief and discussing birth position preferences. So this trial was basically conducted in large, busy public tertiary care hospitals in one Indian state where there was a high C-section use. Partograph were basically completed by postgraduates and by nurses in one hospital, that is the MCH hospital in Gokak, which was Laksha accredited. And the problem here was implementation of the complete package of the supportive care was not possible at all these hospitals. Insufficient manpower at all levels of care, and influence of patient relatives and local leaders in the management of the patients, and the use of 5 centimeter dilatation to define the active first stage, as well as removal of the 1 centimeter per hour rule, led to poor intrapartum interventions. And more actually speaking, most of the C-sections are done prior to the onset of active labor. We need to focus even on that, because whenever we plot a labor care guide is we start plotting after the active phase of labor, where hardly we see any C-sections done, because most of the women rapidly progress unless we have some problems in the second stage of labor. So it is really challenging to generate provider behavior change in settings without a national policy framework, and training is the main backbone for training of labor care guide. So the presence of wide confidence intervals stemming from variability in the outcome rates and the small number of clusters necessitates cautious interpretation of our findings. And this, as an exploratory pilot trial, the study's design limits the ability to draw definitive conclusions on the magnitude of the labor care guide strategy's effect. So definitely we need larger scale definitive trials using a stepped wedge cluster randomized design and involving more hospitals with high cesarean C-sections for further evaluate the efficacy of the labor care guide strategy and its impact on the maternal and neonatal outcomes. So basically, definitely labor care guide improves the labor monitoring. It encourages evidence-based care based on the latest WHO intrapartum care recommendations, promotes women-centered care, facilitates timely decision making because there are alerts which are there in the labor care guide, supports healthcare workers and adaptable to different settings. So if you properly train the caregiver, it could be a nurse, it could be a postgraduate who's conducting delivery, who's monitoring labor, definitely introduction of labor care guide, then definitely reduce the C-section rates, especially in the correct context of very high C-section rates in India. Thank you.
Thank you so much, ma'am. That was very, so I think it was a big eye opener because we need to change ourselves. And you said, it said very clearly that the provider is the one who's at fault. So I think we are the ones who have to change ourselves to adapt ourselves to the settings now. Madam, can you answer the questions in the chat box? And then if there's any other question, we'll call you back at 7 o'clock. We'll request you to call you, to come back again. Monica, you can go. Thank you. Thank you so much.
Yes, ma'am. I'm sharing my screen. I request the chairpersons to introduce our next speaker, Dr. Manju Puri, madam. Is my screen visible, ma'am?
Yeah.
Yes, Monica, but slideshow, please.
Dr. Manju Puri, as we all know, she is the star of North, and she's the Director, Department, Ops and Gynae, Lady Harding Medical College, New Delhi, President of NARCHI, Delhi branch, and she's got many awards, edited many books and many numerous publications to her credit. And it's always a pleasure to hear to Dr. Manju Puri, ma'am. Over to you, madam.
Thank you, Raki, for is my screen visible?
It's just started, madam. It's visible now, madam. Madam,
Right.
Can you make it into slideshow, madam?
Yeah, I will. So thank you, Raki, for a kind introduction. And Well, I am now placed at SGT Medical College, so I had changed my, introduction slide. Probably this was the older one. And thank you, Chamila and Dr. Parag, for having me here, and an excellent program.
Thank you,
Great
ma'am.
talks, great insights, and I think it is definitely a real eye-opener on labor for all of us. Okay. All right. So, the topic which I'm going to deliberate upon today is labor care through the prism of quality. All right. So let's first understand as to what do we understand by the word quality. So it is only recently that this word has kind of come up. And, we were not talking about quality at all. I guess maybe a decade back. So there was nothing like quality. So, this is the WHO quality of care framework for maternal and newborn health. So we know that it is actually based on Donabedon model of structure, process, and outcome. So Donabedon was a physician and he was also a quality guru. So this framework came up in 2013 when a group of experts were called in to assess the, to deliberate upon how to assess the quality of care which is provided to the mothers and newborns in the labor room. So, we all know that every health system is based, the quality of care, we always kind of say, depends upon the infrastructure which is available, the facilities which are available, the number of, human resource which is available, and the supplies which are there. So we always tend to put quality related to that. But what is important is that quality of care is also related to processes, which are free of all these things, right? So in this model, there were 8 key points of quality of care as far as the processes are concerned. And the first was related to the provision of care. So are we giving evidence-based practices for routine care and management of complications? Are we, rationally giving antibiotics rationally? That is one example. Then, are there actionable information systems available? Right? Are there functional referral systems available? So these are the things, which are related to the processes of care. Then the next 3 key points are related to the experience of care. So is there effective communication between the, the provider and the beneficiary? Is there respect and preservation of dignity? Right? And is there emotional support which is being given? So all these things are related to the quality of care we provide. And there were 2 components which were overlapping, cross-cutting, as far as the 2 main aspects are concerned. So availability of competent, motivated human resource. It is not how many people you have, it is whether they are competent and motivated, that is more important. And then essential physical resources are available or not. So I'm saying essential physical resources, right? So these are the basic components based on which the quality of care is actually decided. Now, simply ensuring coexistence of infrastructure, medical supplies, and healthcare providers and guidelines does not lead to optimal healthcare. We really need to use it intelligently. So it doesn't matter how many resources you have. If you don't know how to use it, then it will never be enough. And that is why you need to have competent people to kind of providing services. So quality healthcare is basically multidimensional. So it has got, it should be safe, it should be timely, it should be equitable, it should be effective, it should be efficient. That means we are not wasting our resources, right? It should be person-centric. I think it is the person-centric part which is very, very important. And we know that in labor, if a woman is fearful or she's anxious, all the catecholamines and other hormones are going to be released. But in case she's comfortable and, she feels she's loved and she's being cared, oxytocins would be released and you will have less of dysfunctional labor. So is quality of care a problem only of public facilities? Because we feel that there are no resources, the ambience is not good and manpower is less. So is it a problem there? Or is it also a problem of private facilities which are well equipped? What we need to understand is that in India, the spectrum of obstetric care ranges from too little, too late in public sector which is actually, said that is mostly available for mothers in low and middle income countries. Two, the other end of the spectrum is too much too soon in private sector, which is related to high income countries. So we have both these ends of care in our country. So quality of care may be suboptimal at both the ends of the spectrum if we assess it along those 6 parameters which we had looked at, 6 dimensions of quality of care. So WHO intrapartum care model for positive birth experience was rolled out in 2018, and it talks about all the things which previous speaker had talked about in the labor care guide. But respectful labor and childbirth is something which is a very, very important component of that. So just introducing to the concept of respectful maternity care, which also equates to positive birth experience, because we know that the person-centric approach is something which is very, very important, right? So RMC sometimes is known as humanization of childbirth. And one of the very important yet overlooked aspect of maternity care is evidence-based care. Not all what we do is evidence-based. We separate the babies from the moms, keep them in the nursery in case it is a big hospital, and then hire antibiotics, hire the hospital, hire are the antibiotics. So, we don't do everything which is evidence-based. Also, what is lacking is, or overlooked is, respect, dignity, and emotional support using effective communication. The obstetrician may be good, but what about your team? There are multiple people who are involved while looking after the mom while she's birthing. So interaction of mothers with providers during childbirth should be characterized by a caring attitude, empathy, support, trust, confidence, and empowerment. So communication must be gentle, it should be respectful and effective to enable informed decision-making. So there was a landscape review which was carried out by Bauer and Hill and was published in 2010, which explored the evidence and action for respectful care at birth. And there were 7 categories of disrespectful care. It was found it was rampant all over the world. It is global. So, physical abuse, non-dignified care, non-consented care, non-confidential care, discrimination, abandonment or withholding of care, and detention in facilities. So all this, there were 7 categories of disrespectful care, based on which the White Ribbon Alliance came up with this Charter of Respectful Maternity Care, the universal rights of childbearing women. So these 7 rights were listed under RMC based on International Human Rights Declaration and Conventions. So, it was initially rolled out in 2011, following that landscape review, which was published, and then updated in 2019, when 5 more, rights were added. One was right to have a birth companion of choice, then right of every child to be with their parents or guardians, right of every child to have an identity and nationality from birth. Everyone has the right to adequate nutrition and clean water. Every woman and newborn has the right to timely and effective grievance redressal. So total of 12 universal rights of women and newborns. So I'll quickly take you through each one of them and with the example. So the first was a right to freedom from harm and ill treatment. So for this, we need to assess ourselves and question, are we using interventions which are not evidence-based, like episiotomy, universal episiotomy, induction of labor, too many induction of labor, time deliveries, cesarean sections, unnecessary antibiotics? Then are we using checklists to avoid errors, like surgical checklist? Do we have surgical checklist, right? Are we teaching communication skills like S-bar and, check back to our nurses so that, medication errors are not there? So, we need to look at that. Then the second is the right to information, informed consent, refusal, and respect for choices. Now here, we need to question ourselves, are we explaining the management plan and procedures, that is induction or augmentation of labor or cesarean section on demand, to the mother in an unbiased manner? So are we telling them what complications are going to be in case she has another baby after cesarean section on demand? And the baby is not going to get exposed to the maternal microbiome, and the baby can have a lot of immunological and other disorders in the future. Are we telling them all that? And are we taking informed consent? So my questions are directed to both the private and the public sector, because public sector, we say we have accepted that the quality of care is poor, but I think it can be improved by interventions by dedicated and motivated people. So it is not only about resources, it is about your behavior. So then do we inform and support her on positions of labor and birth, antenatal exercises, early initiation of breastfeeding? The third right is right to confidentiality. Are the mother's record kept in a secure place, inaccessible to general staff or visitors? Do we discuss personal details about mothers publicly? It need not be the obstetrician. It could be your team. That is what we need to. So I am talking about a team birthing a mother. The right to dignity and respect. How often do we explain and take the consent before doing a PV examination? Sometimes there could be vaginitis and we put our fingers, the patient has so much of pain, we still continue doing a pelvic assessment. Are we looking at the infection before we put in our fingers? Are we sharing the findings of examination per abdomen and PV examination with the woman and family every time? Do we take care of covering the patient up, once we leave the patient after PV examination? Do we listen to the woman carefully? So there are so many questions and there are so many, queries which come to my mind, and we know that we falter on most of them. Right to equality, freedom from discrimination and equitable care. We need to question, are we discriminating care based on caste, religion, socioeconomic status, education, HIV status, political connections? I think we all have our answers to that. Right to timely healthcare and the highest attainable level of health. Are we providing full package of services to the mother and newborn at the right time in correct manner? How many of us are putting all the babies skin to skin for 1 hour immediately after birth? How many of us are initiating breastfeeding within half an hour? It is at dismal 40%, right? How many of us are actually doing a delayed cord clamping? Are we ensuring recommended practice for infection prevention for every mother and newborn? How many of us sanitize our hands before touching the patient? We move from one patient to another patient. And there are lots of questions here. Then the right to liberty, autonomy, and freedom from coercion. Are we detaining women in the hospital against our wishes? So all the mothers who go lama, there is something wrong in the system. Right for every child to be with their parents. I'll just complete in another 1 minute. Are we separating the mother from the newborn unnecessarily? Are we keeping mothers and newborn together, even if her newborn is born small, premature, or with medical conditions? There is a concept of MNCU now. Right of every child to every child has the right to have an identity and nationality from birth. Are we doing newborn birth registration even if they die shortly after birth? Don't our neonatologists say that please put it as stillbirth? And are you providing adequate information and support on child nutrition and the advantages of breastfeeding to the moms? Are we allowing our mothers for seeking redressal for grievances? Does the facility have an effective, transparent, and timely grievance redressal mechanism without fear of reprisal or retribution? So we all need to reflect and assess the care we provide to our mothers in labor and their newborns on the various dimensions of quality, identify the gaps and bridge them by taking small steps. There is no giant step that does it. It is a lot of little steps which will do it. Our goal is to provide quality care to our mothers and their newborns. The first step is to know what quality care actually means. So the scope for improvement is infinite, precisely because perfection is unattainable. But it is never too late to take the first step. I am glad Charmila decided to include this topic in this course on labor. And I hope I've been able to ignite some new insights in you as far as the quality of care is concerned. Let every mother and child be a happy and every mother be a satisfied beneficiary. That is what should be our aim. Thank you so much for patient hearing.
Thank you, ma'am, for a thought-provoking talk. And I would request Rakhi madam or Sapna ma'am, if they're there, for your concluding remarks for the first session.
It was indeed a superb lecture as usual, ma'am, an eye-opener, and it was very required also for all of us to understand. And thank you, ma'am, for being there. Let's move on to the next session because of the possibility.
Thank you, ma'am.
Thank you all the speakers for being there.
Yeah. Ma'am, can you please answer the questions in the chat box? Yes, Sapna ma'am.
Yes, it is a very thought-provoking and self-evaluation lecture. I think we all have to think about all these points and proceed with a very good new generation and strong mother. So it's an excellent lecture by Madam. Thank you.
Thank you, Manju ma'am. We now move forward to the next session. Our first chairperson for this session, Dr. Seema Pandey, madam. She's the director at Eva Fertility Clinic. She has been the librarian for the ISAR and the managing committee of ISPAT. We welcome you, ma'am, for chairing this session.
Thank you.
Our next chairperson, Dr. Ranjana Khanna, madam, is the governing council member of ICOG and the executive member of National ISPAT. She has been the past president of Allahabad Obijwai Society. We welcome both of you, and I request Seema madam to please introduce our first speaker for today's session. Ma'am, is the slide visible? Dr. Raja Maheshwari ma'am.
Thank you, Dr. Monica, for your kind introduction. And I would welcome Dr. S. Raja Rajeshwari, who is a consultant, Kalyani Hospital, Pattu Koktari, practicing obstetrics and gynecology for last 18 years, and a gold medalist in her MD Obs-Gyne. Area of interest are obstetric and high-risk obstetrics. And welcome, Dr. Raja Rajeshwari.
Thank you, ma'am. Thank you. Can I share?
Ma'am, I'll just stop sharing. Just a second, ma'am.
Okay.
Now you can start sharing, ma'am.
Yes. It's not coming, ma'am.
You are the co-host. You will be able to see a green button at the end of at the bottom of the screen.
Yes, but that is not opening my file, ma'am.
But you checked earlier, no?
Yeah, yes, I checked. Should I open in?
No, you have opened it in your desktop. No, it's open, no?
No, I just want second.
Ma'am, you need to open the PPT on your desktop and then start sharing the entire screen so that the PowerPoint will be visible, ma'am.
Is it seen, ma'am?
No, not yet.
Not yet, ma'am.
It's opened in my desktop, ma'am.
No,
but you need to share your screen, ma'am.
Okay.
There's a green button in the screen, no? Below share it is written. You go and click there.
Okay, 1 second.
It's opening now.
Yeah. Sorry for the delay, ma'am.
Yeah. Make it into slideshow as earlier.
Yes, ma'am.
Yeah. Thank you very much, ma'am. That was previous speaker, Dr. Manju, ma'am. It was very wonderful talk. Thank you very much. And thank you for the ICOG team for including me.
Raji, Raji, yeah. Make it into a slideshow.
Yeah. It's in slideshow only, ma'am.
No, you again go
and click. No, you need to click on the button, ma'am.
Okay. Resume.
It's moving slowly. I think there is a lag.
Lag color. What she can see on her screen and what we can see.
Yeah.
Right. Perfect. It's now clear. Yeah.
Okay. Thank you very much. At the outset, I like to thank ICOG team and especially Dr. Chamla madam for giving me the opportunity to talk on oxytocin in labor room. Low dose versus high dose. Oxytocin is none other than our labor room tirtham or a holy water in labor room temple that saves lots of mothers and newborns as well as obstetrician if it is used correctly. Oxytocin is a non-neuropeptide hormone. It is one of the 2 hormones stored and released from the posterior pituitary gland but synthesized in the hypothalamus. When the head of the fetus pushes against the cervix, the nerve impulses travel to the mother's brain and activates the posterior pituitary to secrete oxytocin. This oxytocin is then carried through the blood to the uterus to increase the uterine contractions further, and the cycle continues until parturition. This oxytocin primarily acts by elevating the intracellular calcium. Oxytocin is one of the most frequently used medications in obstetrics and for labor induction, and it is a FDA-approved drug.
since 1960s, synthetic oxytocin, that is
Raji,
synthocyanate,
the slides are not moving. Please click on the slides.
in my computer it is moved, ma'am.
No,
Now,
it's
ma'am.
not moving. No, no, no.
I
You
think
just-
you need to off your camera and then do it. It will move because it is a lag in between.
Yeah, 1 second, ma'am.
Off your video and then do it.
Okay, 1 second. Video.
Otherwise, you go on to the slide and then click on the slide. Then it starts moving.
Okay. Now can you see, ma'am?
We can see, but please move the slides. Let's see whether it moves.
Ma'am, you need to use either the arrow keys on the keyboard. If that up and down keys are not
Now-
moving, you can use the left and right key also, ma'am.
Now it's moving, ma'am.
Next
Oh,
slide, next slide.
no.
Move to the next slide.
Yeah, I'm moving.
No, it's not moving.
The screen is frozen.
Ma'am,
Click
you
on-
must have stopped, you must have paused sharing, ma'am.
No, ma'am. Sir. Okay. Yes, ma'am.
Ah,
Sorry for the delay.
no.
Okay, ma'am. Now is it seen?
It's seen, but it's not in slideshow, but it's okay. You just move your slides. I think it'll move here
Okay.
better.
Okay, since 1960s, the synthetic
Move
oxytocin
the
has been-
slides. Move the slides. Move the slides.
You need to come on to the slide that you are speaking, ma'am.
Yeah,
It's not moving at all.
it's mine. It is moving.
No, no.
Here it is moving now.
Just click on and on, it'll go.
Okay. Now is it visible, ma'am?
It is visible, but it's not moving, I'm saying.
Ma'am, if you come on to the left side where the slides are seen, the first 4 slides, whichever slide you want, you just double click on that slide. It will open that slide, ma'am.
You can reshare. Just log out
Log
and
out and log in again.
that might help.
Stop sharing it.
Okay,
And then
ma'am.
there's a button down, red one, stop sharing.
Mo-
Do
Moni-
that and reshare it.
Monica, please help her. By the time we'll have Pranjal's talk.
Okay.
Yes,
Monica, please help Raji.
I'll just, sure.
Just share
Okay,
the
ma'am.
CV of Pranjal so that Seema can introduce her.
You want me to stop sharing, ma'am?
Yeah, please stop sharing. Okay. Seema, you there? Seema. Okay, I would like to introduce Dr. Pranjal Sharma. She's a director, Sharma Hospital, Amravati, and she's also the zonal coordinator of AMOGS, as well as the president of the Amravati Society of 2023 to 24. May I now request Dr. Pranjal to give her talk on contractions, the clinico-electronic details. Pranjal, you can start. Pranjal, we are not able to hear you. Unmute yourself. Pranjal.
Yes. Now I am audible.
Yeah, audible. Audible. Yes.
Okay.
Ah.
So good evening, everyone. At the outset, I would like to thank and convey my respectful regards to Dr. Parag Binniwale sir, Chairperson ICOG, Dr. Sarita Bhalerao madam, Dr. Sadhna Gupta madam, and my dear friend Charmila. Thank you so much for giving me opportunity. I am given an opportunity to talk on the uterine contraction during labor, which is bit topic, very interesting, very important. Dear friends, my slides are also not moving.
You just moved. You just click on the slide. It's moving. It's moving.
It's moving.
Yeah, it's moving.
Yes. The power and intensity of contraction cannot be stronger than you because it's you who have a mighty organ inside called uterus. So let us start about the uterine contraction. Normal labor and delivery are dependent on regular and effective contraction of the uterine myometrial activity. The mechanism responsible for initiation, maintenance of adequate and synchronized uterine activity that are necessary for labor and delivery are a result of a complex interplay of hormonal, mechanical, electrical factors and factors not yet fully elucidated. Is the muscular layer, just a moment. Is the middle muscular layer, which is known for rhythmic contraction. When the contraction in non-pregnant uterus are there, they are called as the endometrial waves. Braxton Hicks when during whole pregnancy and true labor at the end of the delivery. Uterine contraction has following components, that is fundal dominance, polarity, coordination, effectiveness, frequency, duration, intensity, interval, and resting tone. The activity of myometrium. Fundal dominance is the activity of myometrium is strongest and longest at fundus, shifting towards midline and downwards. Charmila, give me 1 minute. My full screen is not visible on my laptop.
Yeah, we can see the full screen.
The slides
You
are
can
there.
see?
It's visible.
Yeah,
It's
yeah.
visible here. Yeah, yeah.
So the second component is, the first component is fundal dominance. Another component is pacemaker. There are two pacemaker, one at each corner, from where the wave or contraction spreads downwards. Their activities must be coordinated. Propagation of wave must also be coordinated. Polarity of the uterus when upper segment contracts and the lower segment relaxes. This happens in routine or normal during the normal labor. Lack of fundal dominance and the reverse polarity leads to spastic lower uterine segment. Here pacemaker doesn't work in rhythm. A normal uterine contraction spreads downwards from cornu within about 15 seconds. The contractile phase begins slightly later in the lower portion of the uterus, but functional coordination is such that the contraction's peak is attained simultaneously in all portions during active labor. There is an increase in intrauterine pressure of approximately 10 to 12 mm of Hg, which may increase to 30 mm Hg with hypertonia. Contraction can be palpated abdominally with pressure greater than 20 mm of Hg and perceived by women at 20 mm of Hg. There is an intrinsic excitability of the uterine muscle dominated by hormonal influence during labor. This is due to number and sizes of gap junctions. Gap junctions allow the transfer of current carrying ions and the exchange of second messengers between cytoplasm of the adjacent cells. Increased gap junction interaction will increase electrical impulses and therefore the contractility of the myometrium. Gap junctions are absent or they are infrequent in non-pregnant myometrium and decline markedly within 24 hours of the delivery. Contraction can be mild, moderate, or strong. If the uterus becomes somewhat tense but can be indented with slight pressure is mild contraction. Uterus becomes moderately firm and firmer pressure is needed, that is moderate contraction. And during strong contraction, the uterus becomes so firm that it has the feel of wood-like hardness, and at the height of the contraction, the uterus cannot be indented when pressure is applied by the examiner's hand. In the clinical situation is similar to tip of the nose for mild contraction. The feel is same to the chin in moderate, and it has the feel of forehead in strong contractions. There is a good synchronization of contraction wave of both halves of the uterus. The waves of contraction follow a regular pattern. Intraamniotic pressure rises beyond 20 mm of Hg with the onset of true labor pains during contraction. Good relaxation occurs in between contraction to bring down the intraamniotic pressure to less than 8 mm of Hg. During contraction, the uterus becomes hard and somewhat pushed anteriorly to align the long axis of the uterus with that of the pelvic axis. Simultaneously, the patient experiences pain, often radiating to the thighs. Uterine contraction is involuntary and therefore cannot be controlled by experiencing women. Uterine contraction has three phases: increment phase, increment phase, acme, and decrement or descent phase. The first stage of labor is associated with contraction pressure of 20 to 50 mm of Hg with frequency of 3 to 5 contractions per 10 minutes, window lasting between 60 and 80 seconds before returning to normal basal tone of between 8 to 12 mm of Hg. The second stage of labor is associated with contractile pressure of 80 to 100 mm of Hg with frequency of 5 contraction per 10 minutes window lasting 60 to 80 seconds. When oxytocin is used to induce or augment the labor, it is titrated to cause uterine contraction above 180 MVU. Care is taken to avoid contraction strength about 300 MVU. We are going to learn about MVU shortly. It is reasonable to achieve these levels of uterine activity before considering surgical delivery. Wave begins earlier in some parts than in other, but contraction reaches its maximum in different part of the uterus at the same time. At the peak of contraction, the entire uterus acts as a single unit. Relaxation starts simultaneously in all parts of the uterus. For normal uterine action, coordination is required between both halves of the uterus as well as between upper and lower segment. With effective uterine contraction, it results in progressive cervical dilatation and descent of the head within given time. Rise in intrauterine pressure brought about by contractions measured from baseline resting tone. With external monitoring, this necessitates the use of palpation to determine relative strength. With IUPC, this is determined by assessing actual pressure as graphed on the paper, and with electronic monitoring, it is determined by detection and recording of bioelectrical signal produced by contracting uterus. The lowest intrauterine pressure between contraction is called resting tone. Normal resting tone is 5 to 10 mm of Hg. During labor, resting tone may rise to 10 to 15 mm of Hg. The resting pressure above 20 causes decreased uterine perfusion. The abnormal uterine actions are of three types: hyperfunction, hypofunction, and incoordinated uterine actions. In absence of obstruction, hyperfunction leads to precipitate labor, and in presence of obstruction, hyperfunction leads to pathological retraction ring formation. These two slides I'll skip because these are of biochemistry and physiological importance. There are, as we all know, that there are receptors on the uterus. Some receptors are contractility agonist, while other are contractility antagonist. Oxytocin receptors, estrogen, alpha adrenergic receptors are contractility agonist, while progesterone receptors and beta-2 adrenergic receptors are contractility antagonist. These receptors are the targets for multiple drugs used to manage abnormal labor. How we assess? We assess by manual palpation, external tokodynamometry, intrauterine pressure monitoring, and electrical uterine myometrial activity tracing. Manual palpation is a traditional method that involves feeling the abdomen for indenting during contraction. It is inexpensive and harmless, but requires a trained observer. It's subjective assessment that can only detect contraction stronger than 20 mm of Hg. External tokodynamometry uses a pressure sensing device placed on the abdomen to electronically display contractions. Intrauterine pressure monitoring measures the pressure inside the uterus, while electrical uterine myometric activity tracing tracks the electrical activity of the uterine muscles. What we measure? We measure characters. We see for the characteristic of uterine contractions like frequency, duration, intensity, and resting tone. We should be able to distinguish between true and false labor, which depends on the contraction, whether they are regular, whether they are strong, and there is a cervical dilatation along with labor. This is tokodynamometry. It uses a pressure sensing device placed on the abdomen to electronically display contractions. The main advantage of the method are ease of application and non-invasiveness. In optimal circumstances, that is non-obese patient, it can accurately measure contraction frequency with adequate positioning of the transducer and sufficient tightness of the belt. Furthermore, in contrast to manual palpation, tokodynamometry allows the classification of fetal heart rate changes in relation to timing of uterine contraction and providing documentation of contraction independently of staffs present. But it cannot accurately determine the intensity or strength of contraction. In addition, external topography is also influenced by changes in maternal position and abdominal wall muscle contractions such as coughing and vomiting. Also, it is less reliable in cases of obese women. Montevideo's unit are a method. There are two units. One is Montevideo unit. This is a method which is used to measure uterine contraction during labor. They are calculated by measuring the peak uterine pressure during each contraction and subtracting the resting pressure. The sum of these differences over 10 minutes period is MBU. A value of 200 or more is generally considered adequate for normal labor progression. Readings tend to be lower at the beginning of labor and increases with cervical dilatation and pushing. MVs are used to assess the adequacy of contraction during labor induction or suspected labor dystocia. They are also used to calculate the oxytocin dose needed to achieve adequate uterine contractions. In 2014, Obstetric Care Consensus Publication ACOG and SMFM used a criterion of greater than 200 MVUs to define adequate uterine contraction. This criteria was based on 1986 study of 109 women receiving exogenous oxytocin for labor induction or augmentation of labor, in which 77% of women undergoing augmentation reached MVUs of 200 to 224 and 7.7 had MVUs that were higher than 300. In the more recent research shows that 200 MVUs are considered as therapeutic goal for titrating oxytocin administration during augmentation of contraction. These type of calculating units are available on internet to calculate the uterine contraction by Montevideo's unit on internet, and we can very much take use of this tool. An alternative unit to calculate uterine contraction besides Montevideo's unit is Alexandria unit. Some studies suggest that the Alexandria unit may be better indicator of labor progress compared to Montevideo unit alone, as it considers pressure and duration of contraction, both. Intrauterine pressure monitoring or IUPC devices. Some of the above mentioned limitations of external tokodynamometry may be overcoming using these IUPC. This method uses a small bag of fluid introduced between membranes and lower segment of uterus connected to mercury mammometer. Currently, use of IUPC requires its placement within the intra-amniotic cavity following either spontaneous or rupture of membrane, and therefore it is limited only to when delivery is desired. There are 3 types of IUPCs: fluid-filled, transducer tipped, and sensor tipped. And last is electrical uterine monitoring or EMG, which is it calculates the uterine muscle activity monitoring technique that relies on the detection and recording of bioelectrical signals produced by contracting uterus in a similar manner to other better recognized techniques such as ECG monitoring and electroencephalography monitoring. Here it uses the biochemical signals to take the records and to document it. We, as an obstetrician, we are all thankful to millions of women who has allowed us to be their companion during labor, and we respected them like goddess. If a woman doesn't look like a goddess during labor, then someone really is not treating her right. With that, I finish my very big talk of uterine contraction in a given time. Thank you very much. Thank you ICOG, FOGSI, for giving me opportunity to talk in certification course on labor and birthing. Thank you so much.
Thank you,
Thank
Pranjal.
you.
Thank you. As always, very, very clear. No ambiguity whatsoever. As
Thank you
always.
so much.
Ma'am, I have received Madam's presentation now. I will just start sharing my screen now.
Okay.
Yeah.
Raji, you can unmute and you can tell her to move the slide. She'll move it for you. Okay.
Ma'am.
Is the slide visible?
Yeah, it's visible.
Yeah.
Visible.
It's not visible to me, ma'am. 1 second.
Ma'am, can you see it now?
No.
No, you see
Ma'am,
it
not on your screen. You have to see the
there.
screen in front
The
of you,
Zoom.
ma'am.
The Zoom screen.
The Zoom screen.
Yeah.
Ah,
Okay, ma'am.
okay.
Yes.
Change the, you have to
Slide
go to the
show.
4th slide now, Monica.
Yeah,
4th.
yeah. Sorry for the delay, ma'am.
No
Yeah.
problem. Never.
Yeah. Oxytocin is one of the most frequently used medication in for obstetrics for labor induction. Next slide. And it is a FDA approved drug. Next slide. And since 1960s, the synthetic oxytocin has been widely used for labor induction and management. By mimicking the natural hormone oxytocin, syntocinon stimulates the uterus, helping to initiate and regulate the contractions. Next slide. This syntocinon plays a crucial role in obstetric care by aiming to promote efficient uterine contractions, favorable cervical modification, and the progression of labor towards the vaginal birth. This can be particularly beneficial in cases where labor needs to be induced for various reasons. Next slide. Induction of labor is an intervention designed to artificially initiate contractions, leading to progressive dilatation and effacement of the cervix and birth of the baby. Whereas augmentation is an intervention initiated when progress of labor is delayed following spontaneous onset of labor. Next slide, please. Syntocinon can be used for both induction of labor and augmentation of labor. Next slide. Intravenous oxytocin is one of the most commonly used method of induction for women with a favorable Bishop score. Oxytocin can be used alone or in combination with amniotomy or following cervical ripening. It can be continued further for augmentation of labor. Next slide, please. The only FDA-approved drug for augmentation of labor is oxytocin. Augmentation of labor is done when there is delayed progress. Next slide. There are 2 regimes based on the amount of starting dose, rate of incremental dose, and the intervals of escalation. We can divide into low dose regime as well as high dose regime. Next slide. Next slide, please, ma'am. In low dose regime, the infusion rate is started below 4 milliunits. Usually it is 2 milliunits per minute. Whereas in high dose regime, the infusion is started at 4 milliunits, 4 to 10 milliunits per minute. In low dose regime, the oxytocin is increased at an incremental rate of 2 milliunits per minute, whereas in high dose, it is increased in incremental dose of 4 milliunits per minute. Whereas in both the regime, the maximum allowed dose is 30 or 40 milli international units per minute. According to FOGSI guidelines, the maximum dose is 40 milliunits, whereas RCOG recommends only maximum dose up to 30 milliunits. Next slide, please. How to calculate this dose for oxytocin infusion. Each ampoule of oxytocin contains 5 units of oxytocin, and that should be stored in refrigerator at 2 to 8 degrees Celsius. Next slide, please. Oxytocin is administered as dilute solution only by intravenous route. The solution is isotonic solution such as oral or normal saline is preferred over dextrose solution. Labeling of the solution is very important. Next slide, please. Infusion pump wherever available should be used for oxytocin infusion. Close monitoring is needed when routine IV set is used. Next slide. For dose calculation, each ampule contains 5 units of oxytocin. So we'll take 2 ml of oxytocin is taken in a 10 ml syringe and it is diluted with 8 ml of normal saline. That will constitute the 10 ml of saline solution having 10 units of oxytocin. 1 ml of this solution, a saline solution, contains 1 unit of oxytocin. To make a bottle of 2 units of oxytocin infusion, the 2 ml of this solution is added to 500 ml of normal saline or ringer lactate. Next slide, please. So when you add 1 unit of this prepared solution into 500 ml of normal saline, that will constitute into 1000 milliunits in 500 ml. For 2 milliunits in 1 ml. We can use either routine IV set or a drip set. In routine IV set, 1 ml of fluid is equivalent to 16 drops, whereas in drip set, 1 ml of fluid is equivalent to 20 drops. When we use routine IV set, 16 drops will have 1 milliunit of solution. 2 milliunits of oxytocin will be there in 16 drops. When the starting dose is 8 drops per minute, that is going to deliver 1 milliunit per minute. Whereas in drip set, 20 drops is equivalent to 1 ml. So 20 drops contains 2 milliunits of oxytocin. That will go as per drop, it will be 0.1 milliunits. Next slide, please. Next slide, ma'am. Okay. This is for routine IV drip set. Using routine IV drip set, this calculation comes like this. If you are preparing 1 unit solution, that is 1 ml of prepared solution, if you are adding in 500 ml of normal saline or oral, and you are starting the dose by 8 drops per minute, that is going to deliver 1 milliunit of oxytocin per minute. You are going to increment the dose by 8 drops, 16 drops, 24 like that up to 64 drops. If you are going to infuse 8 drops per minute, that will deliver 1 milliunit, whereas 64 drops will deliver 8 milliunits of oxytocin per minute. If you prepare a 2 unit solution, 8 drops will have 2 milliunits per minute, whereas 64 drops will deliver 16 milliunits per minute. Next slide, please. Next slide, please. Please don't get confused with this slide. Again, now drip set. When you are using drip set, wherever available, drip set infusion set must be used. In drip set, there are 2 methods. One is drip infusion method. Another one is volumetric method. Next slide, please. In drip infusion method, 5 units, that is 1 ampule of oxytocin is added to 500 ml of diluent, NS or oral solution. This will make each drop will contain 1 milliunit of 0.5 milliunit of oxytocin in 1 drop. If you are going to infuse at 1 drop per minute, next slide, please. That will deliver 0.5 milliunits of oxytocin. If you are going to deliver at 10 drops per minute, this will deliver 5 milliunits per minute. If you are deliver 20 drops per minute, that will deliver 10 milliunits of oxytocin. Next slide, please. Next slide. That will deliver 1 ml of the solution. The next one is drip infusion method, that volumetric infusion. That is, this goes volume against the time. If you are going to deliver 1 ml in 20 minutes or 10 ml in 20 minutes, like that, we have to infuse. This is syringe infusion pump. Here, next slide, please. Here, the setting is made 1 ml in 20 minutes. If you are going to deliver this through syringe pump 1 ml in 20 minutes, that will deliver 0.5 milliunits of oxytocin per minute. When you are going to deliver 20 ml in 20 minutes, that will deliver 10 milliunits of oxytocin per minute. Next slide, please. So to a total amount of 200 milliunits in 20 minutes, this is going to deliver. This is how we use drip infusion, low dose or high dose. We have to calculate and infuse. Next slide, please. The oxytocin infusion can be increased until labor progress is normal or uterine activity reaches 200 to 250 MU units. Next slide, please. Upper limit of the oxytocin, as I said earlier, FOGSI recommendation, according to FOGSI, it is 40 milliunits, whereas RCOG recommends 30 milliunits. Intervals of escalation of oxytocin doses vary from 15 minutes to 60 minutes. Next slide, please. Which is best, low dose or high dose? Various reviews have found that high dose oxytocin compared to low dose oxytocin regimen for treating delayed labor progress may reduce the risk of cesarean section by around 15% without any negative maternal or neonatal outcomes. However, the evidence for prioritizing the high dose oxytocin is very weak. Next slide, please. High dose may shorten the duration of labor, but at the cost of potentially dangerous side effects. Conversely, low doses, while seemingly safer, might not be effective in managing prolonged labor. So the optimal dose of oxytocin for stimulating the contractions in cases of dysfunctional labor remains a subject of debate. Next slide, please. Studies found no difference in cesarean section rate between the high and low dose regimens for the treatment of delayed labor in nulliparous women. Women in the high dose group received a larger total amount of oxytocin and had a shorter duration of labor and had more events of tachysystole compared to the woman in the low dose group without any impact on the other maternal and neonatal outcomes. Next slide, please. Both groups had similar rates of instrumental vaginal birth, whereas in high dose group, the main indication was fetal distress. In low dose group, the main indication was failure to progress. There was no advantage for the routine use of high dose of oxytocin in the management of delay in labor. Low dose oxytocin regimen is to be recommended to avoid unnecessary events of tachysystole and fetal distress. Next slide, please. Monitoring is very important. Monitoring for infusion rate of oxytocin and uterine contraction and fetal heart rate by continuous CTG is preferable. In facilities where the CTG is not available, fetal monitoring should be done by intermittent auscultation every 15 minutes in first stage and every 5 minutes in the second stage. Next slide. Blood pressure and pulse for the mother every hourly, intake output charting. The frequency, intensity, and duration of uterine contraction should be assessed every 30 minutes and with each incremental dose of increase in the oxytocin. Cervical status should be assessed prior to administration of oxytocin. And next slide, please. It may be repeated when there is a non-reassuring fetal heart pattern to rule out presence of meconium, abruption, or a cord accident. Close watch is kept for the clinical features of maternal hyponatremia, uterine hyperstimulation, and uterine rupture. Next slide, please. And unmonitored oxytocin infusion may result in maternal and fetal risk. It possesses a maternal and fetal risk. The maternal risk includes headache, nausea, vomiting, bradycardia, tachycardia, cardiac arrhythmias, myocardial ischemia, tachysystole, uterine rupture, scarred or both in scarred and unscarred uterus. And studies have shown use of oxytocin in the labor is associated with increased incidence of PPH. Next slide, please. The fetal risk would include fetal distress, fetal hypoxia, fetal neonatal death, hyponatremia in newborn, severe birth asphyxia. Next slide, please. Therefore, oxytocin has been designated as a high alert medication. Checklists and standardized protocols for the use of oxytocin have been recommended with the aim of reducing adverse outcomes. Next slide. Special precautions to be taken in previous LSCS, grand multipara, over-distended uterus, in women with myocardial ischemia and cardiovascular disorders, and women with a long QT interval. Next slide, please. And it should not be used in obvious fetopelvic disproportion, complete placenta previa, spontaneous uterine hypertony, non-reassuring fetal heart or fetal distress, 2 or more prior sections, prior classical cesarean section, and when there is absence of indication. Next slide, please. And successful induction depends on the good Bishop score, parity, maternal age, fetal weight, and the proper indication. Next slide, please. If a woman delivers by cesarean section due to failure to acquire either adequate uterine contraction or fail to show favorable cervical changes, despite being on oxytocin drip for at least 6 to 8 hours, it is considered as failed induction. Next slide, please. Next slide, please. To conclude, despite an increased use of oxytocin during labor, the effectiveness of oxytocin for treating abnormal progress has been questioned. An unstructured manner of using the drug prevails, and its use can lead to hyperactive uterine contractions, which have been associated with negative effects on the fetus. Next slide, please. This dilemma underlines a critical question. Can we find a middle ground between achieving efficient labor progression and ensuring the safety of both mother and baby? This ongoing debate highlights the need for further research to determine the most effective and safe oxytocin dosing strategies for labor augmentation. Next slide, please. By pinpointing the sweet spot between the efficacy and safety, we can strive for optimal birth outcomes for both mothers and newborns. Data suggests that oxytocin dosing should be individualized to each patient and not to be based on arbitrary threshold. Next slide, please. Oxytocin comes under a high alert medication. Checklist and standardized protocols are recommended. Close maternal and fetal monitoring is recommended. Next slide, please. Next slide. Internationally, there is no agreement on the standardized oxytocin regime. There is no convincing evidence to show one oxytocin regimen superior to another. High doses may shorten the duration of labor. Low dose is to be recommended to avoid unnecessary events. Dosing should be individualized. Next slide, please. These are my references. Next slide. Thank you so much, ma'am. Thank you for the team for giving me the opportunity, ma'am. Thank you.
Thank you, Raji. So the take-home message is low dose is good enough. Do
Yes.
not go for high dose regimes. Thank you so
Yes.
much. And there are some questions in the chat box. Please answer them, Raji.
Sure, ma'am. Sure. Thank you very much, ma'am.
Thank you. We go on to the next talk. Monica, can you introduce Dr. Parag, please?
Our next speaker for today, Dr. Parag Bhamre sir, is a medical graduate and professional health professional from Jan Swasthya Sahyog WHO, and his focus areas are immunization, maternal and child health, and women cancer initiatives. We welcome you, sir, for your talk.
Yeah, thank you so much, ma'am.
Sir, I have stopped sharing so that you can start sharing your slides, sir.
Yeah. Is my screen visible, ma'am?
Yes, sir. It's
Yes,
visible, sir.
Yeah, thank you so much. And thanks a lot, Parag sir and Charmila ma'am, for this great opportunity. I'm really honored, and it's an honor and privilege to be a part of this this very, very interesting course. So before I start my short session on frontier solutions for maternal health and possibly a talk on some part on remote monitoring for labor, I want to really start with one question. I don't expect answers here directly, but I'll really like to pose this in front of everyone and request you to reflect upon this. Like, do you think it is possible to monitor your patients in real time when you are going to attend ICOG conference 2025 very soon in Pune?
No.
I'm just trying to make you think about it. Do you think it is possible? The second question I'll really like to pose in front of you, and that too for our clients. Like, do you think the GDM positive woman can get a self glucose monitoring and adopt behaviors to manage her own sugars well? And that too with this ghungat and smartphone in her hand.
Probably.
And finally, do you think it is possible to predict high-risk conditions well in advance and provide personalized care plans to your patients?
There is an answer in the chat box saying we'll hand over the cases and go to the conference.
Okay. Though I really believe if you are in Pune, you should be able to enjoy Pune, but whether a remote monitoring is a possibility, that was the question.
Okay.
And with these three questions, I just want to mention here that if answer to these questions is yes from your end, then I'll really like to appreciate the efforts that you're putting to update yourself, because today the entire care and practice and system is actually moving towards these different digital solutions. That's what we are hearing today, right from Dr. Hima ma'am's talk to the latest talks that we had from other speakers. So in next 10 to 15 minutes, 10 minutes max, I'll be representing some work that we at Jopaigo are doing. Jopaigo is a public health organization and a Johns Hopkins University affiliate, And we have been working on this particular intersection of technology and maternal health for last few years, and obviously in close collaboration with FOGSI. In my talk, I'm going to cover only 3 major journeys. And this is again what Dr. Manju ma'am actually mentioned, right? In India, there are different ways and different forms of care that are provided at different levels. But the good news is that we are actually achieving and probably have already achieved the double-digit MMR numbers. But different states in our country are actually not at the same level, right? There are states like Maharashtra and Tamil Nadu where we are seeing that these sustainable development goals have achieved, but we do have states like Assam and Madhya Pradesh where there are challenging situations and scenarios. What we are trying to do, or we probably will do with these digital solutions, is to see that the entire country actually achieves the final milestone of sustainable development goal probably at the same time. But if we really want to do that, and as we all know, that initially for last 2 to 3 decades, the entire effort was to ensure that the clients that we are serving should actually come to the facility, or they should at least have access to the essential care elements, right? So the first component that we all were trying to have is access. Eventually, like Manju ma'am again mentioned this in our talk about quality, right? But I really want to open it to the next stage, which is nowadays have much more importance, and that's continuum, right? And it has more and more importance when both public and private sector service providers have a lot of interdependence. And now why I'm saying this, that I'll just like to show with this small infographic, this is the second journey that I want you to take your attention to. Whenever whenever we see a eligible couple, maybe in rural area or an urban area or a semi-urban area, and if woman misses her period, she essentially visits the nearest antenatal care service delivery point. It could be a VHSND for 70% of our women, or it could be a private setup, or it could be an antenatal care clinic. Based on her history, investigation, and examination, if she is detected as high risk, she is sent to the nearest, additional, a service provider or a medical doctor or an OBGYN for additional workup. Now, this provider, if believes that the condition is serious or needs additional attention, the woman possibly goes to a subsequent service providers, sometimes for sonography, sometimes for additional investigations, right? And we also know that there are preferences with respect to, where to go when there is a first child or second child. It's mother's place, or, whether woman will stay at the mother-in-law's place. So all of those complexities make it really, really complex. And this gets even more complex when there is a time of childbirth, right? And all these different combinations and referral pathways, really make this entire care fragmented care. And you may believe that this is a hypothetical picture, but if I take your attention to these numbers down there, this is actually visible in different surveys and data points or the reporting systems that we have in our country for some of the states. Now, why I'm telling this, because the continuum of care across public and private service providers or different types of service providers is an absolute need of the hour. And this end-to-end tracking of maternity event is actually going to make everything much, much better for clients, for system, and for we all as a practitioner. Now, you will say that this is all at a system level, but what I can do at my level, right? So whenever we talk about digital systems, we all know any computer essentially will have input, processing, and output tools, right? So I really want to, have this earnest request that at least at our level, if we improve the way we are inputting our data, if we can really improve the way we are maintaining our data, probably we can add our bit effort to make this continuum, much more stronger and robust. Today, what is happening, the poor inputs that are going in this entire system is leading to suboptimal processing of data points. It leads to lack of adequate information and very poor insights, which ultimately reflects into the poor service delivery or even patient outcomes. And when we know that there is an acceptability to digitize or digitalize records, I do believe that that is a great opportunity that we have. Now, I just want to also give you one example, which we, got to demonstrate in collaboration with government of Madhya Pradesh, and that too with auxiliary nurse midwife in the periphery of, Madhya Pradesh. These auxiliary nurse midwives, which provide care to women from remote and rural geographies, were actually given this sort of bags with all the essential equipments with them. But the one major addition that was done in the equipments is the Bluetooth function for all the major possible, all the major equipments that are required for vital monitoring. And I'll give you an example of, let's say, weighing machine, blood pressure machine, fetal Doppler, hemoglobinometer, glucometers. These things were provided a Bluetooth function. Now, when this simple Bluetooth was added, and what exactly happened, that I'd like to show you in this short video. Like this is an entry screen that these ANMs use. There are various vitals available. Whenever a woman stands on the weighing machine, the reading that comes in the machine directly comes in the digital platform that is available. And the nurse or the staff do not have to enter these readings manually. And this is a major difference that that comes when you have Bluetooth function in it. Now, you may say that such Bluetooth and ensuring that it happens at mass level would be a challenge. Yes, it was a challenge when we started, and it is a 18 months project that and the findings from that I'm sharing with you. It has problems in the initial phase, but eventually now if you see the entire modality is a bit more mature, and more than 85% cases are actually entered through Bluetooth enabled function. Now, what this led to? This led to actual improvement in the data quality. And in many of our facilities, we observe that whenever baby weight is mentioned, it is generally 2.5, 3 or 3.5. Whenever blood pressure is mentioned, it is 120, 80, 110, 70 or 130, 90. So, and all of that is called as hipping around average values. What we observe that when transcription error is reduced, the hipping around normal values is actually dramatically reduced. And if I take your attention to weight, you can see here that from 51% it reduced to 2%. And same happened with other vitals. Eventually, what it leads to is increase in the detection of high-risk pregnancy. The figure in the first slide that I showed, where we are intending to detect high-risk pregnancies early, that effort is actually possible if we do these simple digital solutions. If you see here, the weight-related high risk actually increased in the system from 18% to 25%. Now, mere addition of Bluetooth, with which we are probably attending this meeting at this point in time, can improve our data sets, improve our systems much, much, much better, and can help us to identify those women who need additional attention. And all this data is actually even available in live whenever you have such robust systems and such digital platforms in your routine practice. This is a real snapshot that I'm showing for the state of Madhya Pradesh, in which 50 hospitals are using it. The remote monitoring of the labor is possible by the administrator of all these units. And you can see which cases are at high risk because of any of the vital parameter, or which cases are actually in which phase of the labor, and where exactly is the client right now in your facilities. And all of these data obviously later on can be analyzed for more and more insights. When we think about cost, and that has always been a question to us, but if you look at this cost at scale, it's only a marginal increase in the cost. But the value that such reduced transcription error brings is immense. And the moment you have better data in your system, the ability of creating predictive analytics, ability of generating, AI ML models based on it is a reality. And I'm again glad to share that in collaboration with government and some professional associations, we have been able to create such artificial intelligence algorithms for maternal and newborn health complications. And very soon, probably, we will see the actual deployment of such algorithms. With Ayushman Bharat Digital Mission being there, we really want to propose, I'm just on the last slide, we really want to encourage everyone to look at it positively and leverage all the possibilities and opportunities that we get on this digital ecosystem. Finally, this is the last slide, and that I want to end with a call to action for all of us in a way. that we need to accept this particular change that is coming in the entire care provision. We really need to collaborate with, along medical professionals and tech experts, because many times technology needs those medical insights and actual on-site practical insights. We need to add to the voice to encourage and advocate for better policies, to support digital initiatives. And finally, we need to empower ourselves and our clients. With this, I again want to thank organizers, Parag sir and Charmila ma'am for this opportunity. Thank you so much.
Thank you, Dr. Parag. Thank you so much. And this all is an eye opener for most of us. Like, we need to keep in touch with technology and use it for our regular practice also. Otherwise, we are not going to audit ourselves. We are not going to improve ourselves also. Thank you so much for that wonderful talk. And we're extremely honored to have the Secretary of ICOG, Dr. Sarita Balarao, joining us today. Thank you, Sarita. I know you are very busy, but you have taken out your valuable time to join with us. Can we have a few words from you before we start the next session?
Thank you very much, Dr. Charmila, and my thanks for organizing this wonderful course. I have been listening to the talks, and I really think they're fantastic, this whole concept, and it's really, really very good, and it's going to help us a lot. I think we can move on to the next session. I'm happy to begin the next session if that's... Should I go ahead?
Yeah, Dr. Monica,
Dr.
please
Pratik.
introduce Dr.
Yes, ma'am.
Sarita and Dr. Pratik. Yeah.
Dr. Sarita Bhalerao, Madam, is the Secretary of the ICOG, the immediate past Chair of AICC RCOG West Zone, the past President of AMWI Mumbai Branch, and the President of Mumbai OBGYN Society in the year 21-22. We welcome you, ma'am, and it's an honor to have you with us today. Our next chairperson is Dr. Pratik Kambe, sir. He has been the Governing Council of ICOG for this term too, the Governing Council of the ICRM, and the Patron and Managing Committee member of MOGS since 2013. We welcome you, sir, to chair this session. This is Dr. Aruna Kumari, Madam's biodata, sir. Sarita, ma'am. So, please introduce her.
Thank you, Dr. Monica, for that kind introduction. And we move on now to the next session, and we have 3 wonderful talks with very renowned speakers. And I'm delighted to introduce Dr. Aruna Kumari. She's our first speaker. Dr. Aruna Kumari has done her postgraduate from Chandigarh, and she's the ex-associate professor from the GSL Medical College Rajamundry, and she's now a senior OBGY consultant in the Rajamundry. Her areas of interest are infertility and high-risk pregnancy. She's conducted many CMEs and also invited as faculty at many state and national conferences, and she's going to speak to us on special situations in labor. Over to you, Dr. Aruna.
Thank you, madam. Thank you for your kind introduction. Thank you, Charmila madam and ICOG team for giving me this opportunity. Madam, am I audible?
Yes, ma'am, you're audible. You
Yes.
can start sharing your screen, please.
You're audible.
Yes. I am sharing it. Is it visible, my screen?
No, ma'am.
Not yet, ma'am.
Okay, 1 minute.
Yeah.
Is it visible now?
No, madam. Not yet.
I think the organizers have to make you co-host because we're still seeing the...
No, she is
Till now.
co-host, Sarita. She is co-host.
Is it okay, ma'am? Now, is it visible?
No, not yet.
No, not yet, ma'am.
Now it's there.
Now it has
it's there.
started, ma'am. You have to make it full screen, ma'am.
Yeah, I'll do that. Thank you. Yeah, now is...
Yes, ma'am.
Yes.
Okay. Today, my topic for discussion is special situations in labor. That's obesity, fetal growth restriction, and abruption. Coming to management in obese patients, as we all know, obesity has become worldwide epidemic, and according to WHO statistics, in 2022, 1 in 8 people in the world were living with obesity. So there is an increase in reproductive age women who are obese and overweight, with its associated complications starting from conception till labor progression. So today I'm going to speak on the labor complications like prolonged labor, increased chance for induction of labor, or increased chances of operative intervention in this group of people. So what is obesity? According to WHO, BMI more than 30 is considered as obesity. And now the clinical practice guidelines are using alternate classifications of obesity like Edmonton obesity staging system, which are considering metabolic physical and psychological parameters along with increased BMI. So they focus on associated comorbidities like preeclampsia, diabetic complications, renal complications, along with functional impairments and incapacitating osteoarthritis, along with increased BMI in formulating clinical guidelines and predicting the adverse outcomes. So they are more useful classification systems. Coming to intrapartum issues in these obese patients, the labor is prolonged in these patients, both latent phase and the active phase, and there's increased risk of labor induction, and the monitoring of uterine activity and fetal heart from external CTs is more challenging in these patients, and there is increased rate of failed induction. So coming to each part, the progress of labor in these obese pregnant women. As this graph shows, as the BMI increases, the duration of latent phase is increasing. In one study, it showed that as the BMI increasing from 18 to 40, there's increase in active latent phase from 12 hours to 22 hours. The mean duration of latent phase in this obese group is 24 to 36 hours. Similarly, there is an increase in active phase also. As the BMI increases, the duration of active phase is also increasing in many studies. When we are having these obese patients in our labor ward, we should have a BMI specific partograms which should show the active phase 1 centimeter in 2 hours. Many studies showed that expected duration in second stage is same in obese and non-obese patients. Coming to induction of labor in this group of patients, there is increased indications for induction of labor in this obese group of patients, maybe because there is increased pre-existing conditions associated with this group of people like pre-existing diabetes mellitus and chronic hypertension, and there may be increased pregnancy related comorbidities like GDM and preeclampsia and macrosomia and IUCR in this group of patients, which may increase the indications for induction in this group of patients. And to reduce the risk of term stillbirth in this group of patients, many studies showed that obesity was associated with 25% of all stillbirths that are occurring between 37 to 42 weeks. To decrease this incidence of stillbirths, there is an indication to induce these patients around 39 weeks. Coming to post-term pregnancies is more common in this group of patients. As BMI increases, the odds of spontaneous labor progressively decrease. So there's indication for induction in these patients to avoid post-term pregnancies and associated complications. What is the optimal timing for induction in this group of patients? First, as we already seen that IVF is greatest at 39 weeks. So before 39 weeks, and many studies showed that there's a greatest chance of vaginal birth when we induce these patients between 39 and 40 weeks. According to this study, the induction of labor at 39 weeks versus expectant management in this group of patients showed it was associated with lower rate of cesarean sections and lower maternal morbidity and perinatal morbidity. So the consensus is the induction of labor at 39 to 40 weeks gestational age is associated with greatest rate of vaginal birth and lowest risk of adverse perinatal outcomes. What is the optimal method of induction? There are many studies, but they are very small sample size. So we have to interpret them with caution. According to these studies, the combination of Foley's catheter with oral misoprostol is very safe and effective in this group of patients, but there is a longer duration and greater dose of PGE1 is required with increasing BMI. And PGE1 has more potent binding receptors and increased myometrial effect when compared to PGE2. And with Foley's catheter and misoprostol induction with increased dose, the 75% inductions are ended with successful vaginal birth. Coming to augmentation of labor in this group of patients, we should wait for effacement and minimum contractions with misoprostol before doing ARM. Many studies show that early amniotomy in this group of patients is associated with increased rate of cesarean section and prolongation of labor. Use of oxytocin, yes, but the rate, dose, and duration of oxytocin is increased with maternal BMI, maybe because of the dilution effect of increased distributional volume. So we need more oxytocin to get the same effect. So when we are using higher oxytocin doses, we should have this oxytocin safety checklist in our labor ward. Before we increasing oxytocin every 30 minutes, we should make sure that this baby and mother are doing good. So all these patients should receive early epidural or other forms of analgesia in labor because it's a prolonged labor in these patients. And coming to the TOLAC, many studies showed that the previous cesarean section in obese patients, the chances of failure of induction of labor is very high. If this BMI is more than 40, it is recommended to go for repeat elective cesarean section rather than giving VBAC in these patients to get good outcomes. All these patients should receive VTA prophylaxis and antibiotics to avoid complications with obesity. Coming to failed induction, lack of adequate cervical and uterine response to misoprostol or oxytocin, or failure to progress despite of adequate uterine activity is considered as failed labor induction. The predictive factors are as follows: lentiparity, advanced maternal age, or higher BMI categories, and low Bishop scores at the time of induction. And this table shows as the BMI class increases, the chances of failure is increasing. These are the factors for failure of induction of labor. Coming to delivery plan, when we are planning to deliver these obese individuals, first we should counsel them properly regarding the mean time for cervical ripening, mean time for delivery, and we should prepare them for long labors, and we should advise them to have an analgesia during the labor, and we should ask them to have good nutrition and up and above around, and we should also counsel them for the chances of failed induction and chances for emergency cesarean section. When we plan this induction of labor around 39 weeks, we should recalculate the BMI, and we should have a Bishop score around 38 weeks, and we should estimate the chance of failure, and we should counsel them. If the BMI is more than 40 with unripe cervix, if the BMI is more than 60, and if the EOS is class 3, we should consider elective CS directly because the failure rate is very high in these individuals. This induction of labor chart, when we decided for induction of labor, the proper method is we should place the Foley's catheter. After 12 to 24 hours, we can start with misoprostol. Once the adequate contractions are there and cervix is around 4 centimeters, we can do the amniotomy. If there are no adequate contractions, we can augment it with oxytocin and we can try for normal delivery. The take-home message, we can do induction of labor in all obese patients between 38 to 40 weeks to good results. And the informed counseling should be done because regarding the chances of success, risk of morbidity, and expectation of prolonged labor. And the expected long duration first is the latent phases around 24 to 36 hours in this group of individuals, and active phases 1 centimeter per 2 hours. And Foley's catheter along with PGU1 is the optimal mode of induction of labor in these patients. Expect higher doses and duration and maximum rate of oxytocin to have a good success rate in this group of individuals. Thank you. Going to for next session, next group of patients, that is FZR pregnancies. Fetal growth restriction occurs in 10% of pregnancies and is a leading cause of infant mortality and morbidity. Early diagnosis, optimal fetal surveillance, and timely delivery balance the risk of prematurity against that of stillbirth, and continuous intrapartum fetal heart rate monitoring and early decision towards cesarean section will reduces the perinatal mortality and minimizes short and long-term morbidity in these patients. What is FGR? The AC or estimated fetal weight less than 10th centile is considered as FGR, and it can be early if it occurs before 32 weeks, and it is late if it occurs after 32 weeks. So optimum timing of delivery is very important to improve perinatal morbidity. So close monitoring of fetal growth is very essential. The timing and route of delivery is based on fetal factors and maternal factors. Maternal factors is associated comorbidities, and fetal factors are gestational age, fetal weight, Doppler findings, biophysical profile, CTG, etc. This algorithm will give us a rough idea about the timing of delivery. If all these babies should be have a fetal surveillance with uterine or umbilical artery Doppler and CTC. If there is any non-reassuring CTC, these babies should be delivered. All babies with normal umbilical artery Doppler with estimated fetal weight more than 3rd centile can be taken up to 38 weeks. If they are less than 3rd centile, they should be delivered around 37 weeks. If there is decreased end diastolic volume in umbilical artery Doppler, we should deliver these babies around 37 weeks. Mind you, all these babies should be properly followed up according to protocols with umbilical artery Doppler and CTGs and biophysical profiles. Any non-reassuring CTGs and biophysical profile, they should be delivered. If everything goes well, then we can take them up to 37 weeks. If an absent end diastolic volume, we can deliver them around 33 to 34 weeks in reversal of flow. around 32 to 34 weeks. Route of delivery, cesarean section when the FGI is complicated by absent or reversal of endogastric volume or a preterm growth restricted fetuses with signs of adaptive fetal compromise like vectus venous flow is abnormal, non-reassuring CTG, poor biophysical profile. Induction of labor is not contraindicated in this group of babies, provided their term FGRs with only decreased endogastric volume with reassuring CTG. And there should be a less threshold for conversion of these inductions or labors into the cesarean section because these babies tolerate the labor very poorly, and we should not subject them to acute hypoxic insult because already they are undergoing chronic hypoxic insult. Coming to preparation, all these fetuses should receive administration of a course of antenatal corticosteroids to facilitate lung maturation before 34 weeks, and administration of magnesium sulfate to improve the neurological and antibiotic prophylaxis. Just 2 minutes, madam. So in coming to induction of labor in these FGR babies, cervical ripening mechanical method is safer than prostaglandins. And the Bishop score is good, we can go directly with the oxytocin. Early RM should be avoided in preterm and FGR patients. Continuous intrapartum fetal heart rate monitoring is must in these babies. And if there is non-nourishing fetal heart rate on emergency, LICA should be done within 30 minutes. There is no role for prophylactic forceps. Take home message: timely delivery, continuous intrapartum fetal heart monitoring, early days of cesarean section is a must in all these babies. Coming to labor management of abruption, prompt intervention can reduce the risk of abruption both for the mother and the baby. All these patients should be admitted and evaluated promptly in the labor unit to establish the diagnosis, to assess the maternal and fetal status, and to ensure appropriate management, that is maternal stabilization, recognition of coagulopathy and administration of component therapy, and to deliver them. This is classification. Coming to monitoring, first we should take proper history and dental examination to establish the diagnosis, and to look for the uterine contractions. We should perform an ultrasound to confirm the diagnosis and to rule out other causes of the bleeding. And the gestational and fetal status should be rapidly and accurately assessed, and we should start intense continuous fetal monitoring because these babies, around 60% of babies who are good at time of admission may deteriorate as the time progresses, and we should have a close maternal monitoring of the hemodynamic status, the heart rate, BP, and respiratory rate, because these mothers can also deteriorate with time because they can develop coagulopathy at any time. So RH immune globulin should be administered to all these patients who are required. We request this. To coming to maternal stabilization, we should insert the large bore IV cannula, start crystalloids, insert urinary catheter. We should do the lab work, and we should cross match 2 to 4 units of blood and keep it ready for if this patient deteriorates, she needs it. And we should administer crystalloids and blood components as per the requirement of the mother. Our aim is to maintain the hematocrit more than 25, platelets more than 75,000, fibrinogen more than 3,000, and prothrombin time more than 1.5. Approximately 50% of these patients may manifest coagulopathy as time goes by. It is presented as thrombocytopenia, prolonged PT, etc. The bedside test, that is clot time, is very useful in diagnosing coagulopathy. If this clot should form in 6 to 8 minutes, if it doesn't form or it lyses within 30 minutes, that indicates the coagulopathy. It's a very easy test to diagnose coagulopathy, and we can start treatment with before getting our lab results. This table shows various blood components available and their indications.
I think, Dr. Aruna, your time is getting up.
Yeah, this is my last slide, madam. Coming to definitive treatment, the factors influence the route of labor, severity of rupture, maternal hemodynamic stability, and fetal status. And presence of this flowchart shows how to manage these babies. If the term baby, vaginal delivery is the good option. If the mother or baby are unstable or with contraindication, then we can go for cesarean section. The coming to labor room protocols, aggressive management and immediate delivery is the protocol. Usually these patients have a rapid delivery. The continuous careful monitoring of the mother and fetus for any signs and symptoms of deterioration every half an hour should be done. In these patients, usually have a tachysystolia, hypertonous contraction, tetanus contraction, and very rapid labor. Early amniotic is a must in these patients to decompress the uterus, and oxytocin can be added. So if you are taking this patient for cesarean section, the hemodynamic stability should be assured. should be attained, and these blood components should be continued during cesarean section, and cesarean section should be done by a senior colleague of the team. That's it. Coming take home message, abruption is LR emergency, needs aggressive management. We should stabilize the mother and correct the coagulopathies. Labor is very rapid and we should plan the vaginal delivery unless there is contraindication. Less threshold for cesarean section whenever the mother is unstable, non-reassuring fetal heart, unfavorable cervix, we should do cesarean. Thank you. And sorry for little delay.
Thank you. No, thank you, Dr. Aruna. I think you did a fantastic job. We gave you 3 big topics to do in the short span of 15 minutes, but I really think you gave us a very nice overview, and thank you so much for doing that. I'll hand over now to my co-chair, Dr. Pratik Tambe. If there are any questions you can answer in the chat box, that would be better. Pratik, over to you to introduce our next.
Can the
Thank you
tech team
very much.
share the slide for Dr. Pedi, sir? My desktop has hung. I'm just trying to share, but it is not getting shared.
Neelima, can you share, sir, slide? Neelima?
Yes. Share. Yeah.
Share.
Share, please share.
Let me begin by thanking and congratulating ICOG, Dr. Parag Biniwale, Dr. Sarita Bhalirao, and Dr. Charmila, who is the chief convener for this excellent course on labor and birthing. Thank you very much for having me here. I can't think of a better person than the legendary Professor Paili to speak on obstetric rapid response team, a must in every delivery point. We have grown up watching Sir mortality. I'm sure his talk will be excellently illuminating for all of us.
Thank you.
Make it slide
Thank you,
two.
Pradeep. Thank you, Pradeep. Thank you, the ICOG team, Sarita, Parag, and of course, Jamila, for giving me this opportunity. Can I share my slides, please?
Please stop sharing so that sir can share. Yeah. Sir, you can share now. It's visible, sir.
Okay, thank you. When Charmila asked me, I thought this may be of relevance to the practicing obstetricians, and that's why I took this topic of not moving.
I think sir has got muted.
Sir, if you can just click on that screen.
Okay.
So it's seen now, sir. Yeah.
Okay, thank you. I thought of this topic because of its practical importance. This is known by other terms by other people. Obstetric care team, OB team stat, rapid response obstetric team, and obstetric emergency team are some of the terms used for the same team. But we thought ORRT may be more appropriate because that is the obstetric rapid response team. This is because obstetric emergencies are very time sensitive. If immediate appropriate action is not taken, very serious harm or even death may occur. And this concept we have to give up, this golden 2 hours. I hope that professors are not teaching this anymore. That's a myth. We should stop talking about it. We developed interest in this because of our experience in confidential review of maternal deaths, which, as Pratik was saying, we have been doing in the state of Kerala from 2004. When we analyzed these maternal deaths confidentially, we also looked at it whether there was a delay involved. And we found that there were many avoidable deaths if only timely, simple care was available. And that's the point which I wanted to bring to you. Complications like this, which is everyday occurrence in most of the delivery points, postpartum hemorrhage, amniotic fluid embolism, eclampsia, acute fetal compromise, fetal distress, shoulder dystocia, anaphylaxis, all these things need immediate care. And who will give that? Very often, it may be just an obstetrician or a nurse in attendance at that time. And calling for help, even with all our new gadgets of mobile phones, is not easy. So what we are suggesting is that every delivery center should have a team which is designated as obstetric rapid response team. Who should consist of that? It should be the obstetric team, all of them should be trained, and there should be designated nurses who have ability to do the steps required in also along with that venous access. And we'll go to that one by one. So all obstetricians should be trained, and the nurses also should be trained in having venous access. That's the important thing. There should be a public address system to call for help, to alert the team, and special code should be developed. In our center, we developed 2 obstetric special codes. One is code 10 for a crash cesarean, and code 1 as for the ORR team to be brought in, and that's a maternal collapse. And once code 1 in the labor room is announced, the team involved will alert and will come over there. But that is a dream for most of the centers. In small centers, this is not possible. So we should improvise how we can get help. Public address system is not difficult. We should have only some trained nurses. The important thing is at every hour of the day and night, there should be at least one of them available in the hospital. The duty schedule should be such. And the second thing, they should be identifiable with special badges. And they should have a pouch or a bag provided like this, which should contain essential things like a pocket pulse oximeter, a pocket face mask, 2 cannulas, 16 and 18, let us say, small scissors, adhesives, blood tubes, etc., which are required, for which people usually run around when an emergency occurs. So in that pouch, this is there. When the person comes on duty, she wears that particular badge as well as will have the possession of this bag. And wherever the call comes, of course, mostly from the labor room, they should be there available. And they should be provided with a manual because everything cannot be by heart. So a manual which we have produced, ORRT manual, a small pocket book. Actually, if you can see me, this is all a small pocket book, and the pouch has a small bag like this. If we have this, then a pocket mask which can collapse and then can be put in the pocket. Pulse oximeter, and the team should be trained. And the most important requirement is they should be trained in venous access. Just cannulation as well as the open cut down method. For that, the doctor should be trained. Not at all very difficult, but we have all forgotten. The seniors among you would have done it, but new generation, they don't do it. In addition, if the patient is collapsed and the veins are not accessible, even if we have ultrasound guidance, unless you go for the major vessels, it is not easy to access the peripheral vessels. So you should think about intraosseous administration of fluid. We talk about this for the babies, but this can be life-saving even in the adults. We have, of course, machinery available like the drill and the cannula like that, but this can be done with, we can just have, I think because it's not very commonly done, I will just allow this. Tibia is the most commonly and easily accessible, about 2 fingertips below onto the tibia, below the tuberosity. In the slightly towards one side, it needs quite a bit of force to go through the cortex of the tibia. But once you have gone through that and into the center, then we can take out the stillet, syringe, aspirate, and if you see the blood stain fluid, which is the microfluid, and then push in the fluid, that means you are in the right place. We don't have to have the drill and all that. We can improvise on this, but I think this is a life-saving thing, especially in the periphery when a patient is collapsed. And they should be trained in the A, B, C, D of resuscitation. Of course, with appropriate change, if the patient is already on cardiac arrest, it should be C, A, B, D, as you know. And the A for airway, B for breathing, C for circulation, and D for definitive treatment. In our setting, the D is the most important thing that we all should know about. We all should know how to. I will just show you just a few clips only. The definitive treatment is the most important thing in obstetric emergencies. For example, if it's a PPH, the person should know how to do a bimanual compression. I think I have a small clip. Yes, the whole fist inside the vagina and the uterus bend over the fist and compressed while you are waiting for the rest of the health. That should be the way. And other definitive treatment to stop bleeding, we talk about oxytocin, tranexamic acid, everything, but the cannula and the clamp should replace all other methods of adequately and immediately stopping the bleeding. The cannula, multi-hole cannula like that, steel or disposable, and the clamps like that. We have the transvaginal uterine clamp with proper retractors. I'm not showing the video for want of time. And this clamp, the tip of it magnified and shown, applied one limb or the tip, one blade going to the lateral fornix, the other into the cervical canal, pushed up in the lateral fornix once you have reached it, and then it will go to the level of the isthmus and clamp the vessel. You can easily imagine when you do that on both sides, that's the effective way. The advantage of this is, in the case of patients who have already gone into even DIC, this will work. Not that you will completely reverse the thing, but a cannula may not work in a DIC or should not be advisable in a DIC patient. So these steps should be known and trained to all the people involved in the team. Whether you will give special remuneration for those people or a local decision of the management, but there should be an identified team who will be able to give the immediate care required to reverse the trend that will otherwise end up in a maternal death. For example, if there is eclampsia, they should know the initial dose of magnesium sulfate. And the Kerala Federation, since 1990, we have been recommending that the initial dose is 4 grams IV and 4 grams IM, with 1 gram per hour to follow. I know you people will frown at it. FOGSI saying otherwise, Richard saying otherwise. We have been doing and quite happy about it. They should know, the people involved should know the labetalol initial dose, 20 milligram, IV as a bolus, like that, and escalating doses like that. My point is, I'm just touching here and there what those teams should be able to do. Suppose there is an amniotic embolism. You may have to bring in all your faculties, including giving, maybe in no time she will go into cardiac arrest. She will start pouring because DIC will develop. You have to rush her to her crash cesarean. But because of our experience, what we say is that if there is an adequately trained team under the roof, around the clock, they can make a difference. It is actually one of the experiences of a patient like that that made us promote this and spread this message across the state. And they should also be told about perimortem cesarean, and the tray for a perimortem cesarean should be available in every labor room and every emergency room. It doesn't have to be patient, doesn't have to be taken to theater. In the labor room itself, we should be able to do that. Cardiac compression or chest compression. Starting CPR, if you cannot feel the carotid pulse, should be for the person on the spot. And the way, how to apply it, where to apply it, how deep to go. That 5 centimeter depression that should be achieved, and it should be on the sternum and not on the ribs. All these things have to be told and taught to these people. The rate, after every 30 compressions, there is a 30:2 ratio if you have an AMBU for ventilation as well. So the way to give that should also be taught to these team members. If it is an amniotic embolism, the patient has gone to cardiac arrest and she's getting chest compression, you should teach the team about the displacement of the gravid uterus also. Otherwise, the circulation will not be adequately replenished. They should know how to make sure about the airway, head tilt and chin lift, how to achieve that. They should also know how to identify, how to take the proper size of the oropharyngeal airway, which is shown here, from this angle of the mouth to the angle of the mandible, like that. So the definitive treatment for anaphylaxis, initial dose of adrenaline, we should know 0.5 ml of a 1 in 1,000 solution. And in shoulder dystocia, they should know how to do the Mach Roberts as well as the posterior axillary sling traction. This is just a series of pictures to show how a right tube can be made to go around the posterior axilla of the baby and then used for traction, something promoted by Hofmeier, which we found as useful. Actually, that L clamp that I showed you for the transvaginal urinary clamp can be also helpful in taking this tube around the posterior axilla like that. So in conclusion, friends, my suggestion is ORRT, Obstetric Rapid Response Team, is a must for every labor room, big or small. Plan the team depending on the available resources and update them, train them, and of course, compensate them. That's my suggestion. Thank you very much, ICOG, for this opportunity.
Thank you.
Thank you
Thank
very
you so
much,
much.
Professor Paili, for a fantastic talk. And I think this is the need of the hour in obstetric teams all over the country. Because as you said, time is of the essence, and the old outdated concept of 2 hours or 1 hour, golden hour, is actually something which is a myth. Thank you so much for highlighting so many different important points in that very short lecture, sir.
So there
Can
are
we
some
proceed to the
questions in the
next
chat.
lecture?
Yeah. So there are some questions in the chat box, sir. Please, would like your replies in for that.
Thank you.
They're asking about training
Our
courses.
next speaker.
Yeah. Yes, Pratik, please.
Our
Continue.
next speaker is Dr. Geeta Balsarkar, and she's going to speak to us on panorama of near miss in labor. Dr. Geeta Balsarkar has previously been the editor-in-chief of our official FOGSI journal, which is Jogi. She is currently the secretary of the Mumbai OBGYN Society, and she's also a candidate for vice president of FOGSI. She's going to speak to us on panorama of near miss. I think there's some technical issue, so we are not able to see her. Some Zoom issue. Her camera is not switching on, but I request Madam to please go ahead and speak on her chosen
Thank
topic.
you. Thank you, Pratik, for that kind introduction. Paili sir, Charmila told me that you are going to speak after Paili. Dr. Paili itself has given me a lot of jitters. I hope I do justice to the topic, sir. And I also am a part of maternal mortality review meeting in the city of Mumbai. I have been doing this for the past 5 years, and I tell you, it is really an eye opener, like as to how much we can improve even in a place like Mumbai. So my topic here is like the panorama of near miss around labor. Now, why we should talk about near miss actually? Because near miss is also a complication that can happen during pregnancy, childbirth, within 42 days of the termination of pregnancy. It is that balance between life and death that happens. So near misses patient is almost dead but not dead and has come back. So we have got another opportunity to find out what went wrong and how different we could have approached the entire situation so as to give a better outcome next time. So we know that maternal mortality is only the tip of the iceberg. There is a lot of morbidity that is there below this iceberg, and that is what we should actually try to even approach. And near miss is at the top, below the maternal mortality, there is near miss. And if we investigate the near miss, we are sure to learn much more than maternal mortality, and maybe we could even avoid the mortalities. So like if we see the pyramid that is there from the total number of birth, the pregnancy and birth complications, then comes the maternal near miss and then the maternal deaths. Maternal death is relatively uncommon. The near misses are more common than the maternal deaths, and hence I wish each and every institution has a review meeting of their near misses. The more people will get to learn from other people's mistakes or other people's organizational mistakes that we can avoid when we discuss the near misses. Hence, this is a very, very important point to discuss maternal near misses so that we can prevent the mortality. There are a lot of advantages of investigating the near misses. Near misses are more common than maternal deaths. The major reasons and cause for both are the same, and both maternal death and the near misses, so that if we discuss them, we can have valuable information regarding the severe morbidity which can lead to the death of the mother. But if we intervene properly and in time, like sir said, if we intervene at the correct time, we can prevent a death. Investigating the instances of severe morbidity may be less life-threatening, because woman has survived and she herself will be able to give us like where what could have gone wrong. One can learn from the women themselves since they survived, and if we interview them about the care they received, all near misses should be interpreted as free lessons and opportunities to improve our whatever we are providing to the patient. So if we see the range of all pregnancy, from non-complicated pregnancies to complicated pregnancies, and then here non-life threatening conditions to potentially life-threatening conditions. So we have a lot of cases of the maternal near myths that we can actually discuss and learn a lot. So we have to face the present. What happens is the incidence of acute medical and surgical emergencies in pregnancy and postpartum has increased during the past decade and is even expected to increase even further in the near future. This increase has resulted from the change in the demographics of the obstetric population as well as the obstetric practice. We are seeing more and more mothers of advanced age. It is not uncommon to see mothers delivering between 35 to 42. Today, I had a patient who had undergone IVF and came and registered with me at the age of 48 years. Whatever the rules say, still women are getting pregnant at a later age. Medical and surgical comorbidities, diabetics, hypothyroid, hypertension is very, very common along with pregnancies. Increased operative interventions, previous laparoscopies, previous myomectomies, previous cesarean sections, previous all form of surgeries are very common. ART procedures, placental complications, multifetal pregnancy, rising incidence of obesity. All these has changed the demographic of our obstetric practice. Are few well observed reason for increase in wide spectrum of clinical scenarios in obstetrics. Hence, near miss also should be discussed. So if we come to the definition, a woman who nearly died but survived that complication that occurred during pregnancy, childbirth, or within 42 days of termination of pregnancy. Why maternal near miss? They are more common. So we have already discussed about it. These are great opportunities to improve the quality of the healthcare. So if we see the spectrum, we can see that as it progresses, women with complications, potentially life-threatening complications, and then we come to a small group of women like who have actually been near miss, and they can give us great lessons. Now, if we see this, the severe maternal outcome cases were 335 in this particular study. The maternal deaths were 79, but the maternal near miss cases were 256. We must have the courage to admit that this was a near miss and we could have definitely performed better. Actually, many times what happens is when a near miss happens, we try to push it under the carpet, or we try to say, nothing, we could, okay, the woman survived, so, it's okay. But what I want to say is that it is not okay. It is not wrong to admit that we have been through a near miss, and this we can investigate and we can teach people as to how to perform better in the next situation. Though the deaths were only 79, if they were investigated, almost 256 cases of near miss are there, which we can discuss and learn much more. Now, coming to the obstetric complication or during labor, what happens if the live births or stillbirths, the complications during delivery, if there is postpartum hemorrhage, there could be report of profuse bleeding or retained placenta. What happens in the near miss is that the report of nearly dying and profuse bleeding. In eclampsia, convulsions, and the report of nearly dying and convulsions, including epilepsy, and sepsis could be the one. Obstructed labor, this happens, the report of nearly dying with the use of report of a baby stuck and use of saline drip, or report of baby with injection, or labor pains for more than 22 hours. Sometimes we also see in induced abortions and miscarriage, hemorrhage and sepsis, which can give us the near miss. So if we see the criteria to define near miss, there were various criteria which were studied. There is a Galler criteria, there is a Mantle criteria, there is a Waterstone criteria, but what is recommended nowadays is the WHO criteria. So we will discuss more about this WHO criteria. WHO criteria divides the criteria as clinical criteria, lab criteria, and the management criteria. If there is acute cyanosis, patient is gasping, loss of consciousness lasting for more than 12 hours, absence of pulse, heartbeat along with loss of consciousness, change in the respiratory rate, stroke, shock, uncontrollable paralysis, oliguria, jaundice, clotting failure. These are all the clinical criteria for near miss. The lab criteria is oxygen saturation less than 90% for more than 60 minutes, a change in the pH, increase in lactate, increase in creatinine, thrombocytopenia, bilirubin, and loss of consciousness in the presence of glucose and keto acids in the urine. Management criteria, this is what we normally use. Like if there has been continuous use of of vasoactive drugs, intubation and ventilation for more than 1 hour, not related to the anesthesia, hysterectomy following infection or hemorrhage during delivery, dialysis for acute renal failure, transfusion of more than 5 units of PAC cells, or cardiopulmonary resuscitation. If this has been used in the criteria, then if this has been used in the management, then that is a criteria to be called as a near miss. So like what I said, they have divided into clinical criteria, lab-based criteria, and the management criteria. And then we can also divide the near miss depending on the type of organ dysfunction, whether there is a cardiovascular problem, whether it is a respiratory problem, whether it is renal problem, whether it is coagulation or hematological problem, whether there is hepatic problem, urologic problem, or uterine problem, that is which patient needed hysterectomy following hemorrhage or infection, then it is a uterine problem. So depending on the organ dysfunctions, there are certain markers which are clinical science lab markers and management actions which have been taken to manage this particular patient, by which we can classify it as near miss. So if we see the maximum problem occurs with is coagulation or hematological dysfunction, the next is the cardiovascular dysfunction, and then is respiratory dysfunction, then you have other uterine dysfunction or bleeding needing hysterectomy, neurological, hepatic, renal, or all the other organ dysfunction. So it can be direct, because of direct Dr. Pelly, we know that when we investigate the maternal death, first thing we say is direct or indirect, and then we say whether it could have been avoided or not avoided. So when we talk about the direct obstetric causes, it is pregnancy with abortive outcomes. It could be hemorrhage, miscarriage, ectopic pregnancy, hypertensive disorders, gestational hypertension, preeclampsia, eclampsia, obstetric hemorrhage, pregnancy-related infections, other obstetric complications. These form the direct obstetric causes for the near miss, whereas the indirect causes are the unanticipated complications for management, like anesthetic complications, aspiration pneumonitis, arrest during anesthesia, failed intubation, or any of the drug toxicity. Non-obstetric complications like the medical comorbidities that we normally see nowadays, like it could be obesity, cardiac disease, renal disease, pre-existing hypertension, CNS disorders, and death due to any other external causes like road traffic, assault, or any other, also is an indirect obstetric cause. So coming to the category, this could be pregnancy specific, pre-existing disorders which have got aggravated during pregnancy, like anemia, respiratory dysfunction, cardiac dysfunction, endocrine disorders, or it could be incidental and accidental cause that has happened. So these are the other degrees we can classify the near miss. So these are the various publications which have been there, for in some of which is in our journal, the Journal of Obs Gynae of India, and the other journals, wherein they have said that the maternal mortality ratio and that of the near miss, they have compared. So it is almost, the near miss is sometimes 2 times to 5 times more than that of the mortality. So there are various methods to assess the near miss. Like there are options to assess the near miss in different health systems. One is the first option is at the health system level, assessment at level 3, that is secondary and tertiary centers, and the other is at the level 3 as well as the level 2 centers. If anything better could have been done, so that this patient would not have to go through the near miss. So there are other methods like near miss case reviews. We can have confidential inquiries into near miss. We can have criterion based clinical audit. We have structured review like the South African model, and we can also have the home based interviews, wherein the Anganwadi workers go to the patient's home and try to discuss with her as to what were her problems and if these near miss could have been avoided. So there are, just as there are near miss for the mother, there can be near miss for the neonate as well. We have to remember that there could be events which can lead to near miss for the neonate. It lies somewhere in between the sick neonate and the neonatal deaths. We should also keep that in mind when we are talking about the near miss, that we can be having a neonatal near miss also, which needs to be investigated and talked about. We as obstetricians we deal with 2 lives, a mother as well as a baby. So the near miss applies for the mother as well as the baby during labor. Therefore, we should be able to give a good care, timely management, and specific intervention so that this particular neonate has escaped the near miss. So coming to the sustainable development goals, India is fast approaching towards the goals. Hence, we should be very, very careful to, already maternal mortality has improved quite a bit, but if we investigate the near misses, we can be even there even earlier. So near miss is always around you. anywhere, anytime in labor, near miss situations can emerge. Life is a tough teacher and we have to learn well from our near misses. So from simple to high-tech intervention, courage to and clarity is needed to save lives. We do not know when we have to think out of the box and suddenly have to move and perform something so that we can avoid a near miss. So thank you very much for a patient hearing, and thank you ICOG for giving me this opportunity to speak on this important topic. Thank you.
Thank you very much, Dr. Geeta Balsarkar, for covering extensively the concept of near miss in both the mother as well as the neonate. I think that was a very apt presentation to close this entire third day. We had 3 fantastic talks in this session. Again, my gratitude to ICOG, Dr. Parag Biniwale, Dr. Sarita Bhalera, and Dr. Charmila, the chief convener of this entire course. I think we are at the end of the third day, and there's going to be a post-test for which I will hand over back to Dr. Monica Umberdan, who has done an amazing job coordinating for the third day. Thank you again for having me.
Thank you, Pratik sir and Sarita ma'am, for chairing the session. And I thank Dr. Geeta madam and Dr. Paidi sir for their excellent presentations. I would now request Dr. Charmila madam to please conduct the post-test.
Yeah.
The ICOG team, can we?
Yeah.
Yes.
Please put the link and the timer also.
Yeah.
We request everybody to maintain silence while the assessment is going on. Yeah. The link is already there in the chat box. The QR code also will come. You can scan that and you can start your answering the assessment questions. And please submit before the allotted time is over. Otherwise, you may not get your certificate. Thank you so much. Before I put the answers, I'll do the vote of thanks. I know all of you will disappear if we give the answers now. So please stay on for 1 or 2 minutes while we do the vote of thanks. Is Dr. Sarita there or Dr. Parag? Monica, either of them are there?
Ma'am, I can't see them here in the group.
Okay, then we'll finish. Okay. I'm extremely
Yes, ma'am.
thankful to all of you who have joined today. There are some take-home messages which I've observed in the last 3 days. And that is when you see the way labor is tackled in different parts of the country, you can see there are so many variations. And each have got their own way of managing labor. And it was a wonderful session. It was wonderful because we could hear the stalwarts as well as people who are relatively new to FOGSI talking on the different aspects. And the response from the delegates also seemed very, very varied. That is, some do want lots of interaction in each topic, but some do not want to cross the time limit of 7 o'clock. So you cannot have either way. It can be only one. You can have talks within the time limits and interaction probably at the end of the session if it's possible. And probably we can have some master classes on particular topics which seem very, very interesting to the delegates. So we need to do that later on. And I'm seeing that delegates join even after the sessions are over. So that's a new thing. Monica, isn't it new? People join even after 7 o'clock when the sessions are getting
Yes,
over.
ma'am.
And there are so many variations and everything that I think it's a high time that we have guidelines. And that's when you have stalwarts like Dr. Paley sir, Manju Puri madam, Dr. Jem Kannan, and all stalwarts joining, I think it's high time that we have our own Indian guidelines, at least as for labor, because we need to know that. And then I think there needs to be some class on technology also, because scanning QR codes, using Zoom also seems to be difficult for some people. I think we need some classes on that. And I'm extremely honored to thank the entire team. And I would like to thank the coordinator today, Dr. Monica, for doing such a wonderful job. And you were so helpful, Monica. Thank you so much. I'd like to thank Dr. Sunita Tandulwatskar, the president of FOGSI, for giving us this opportunity. And Dr. Parag Biniwale, the chairperson of ICOG. Dr. Sarita Bellarao, Dr. Ashok Kumar, the vice chair. Dr. Swarna Kadilkar, the secretary general of FOGSI. All the conveners of the other days, Dr. Poonam Goyal and Dr. Reshmi Kahar. The coordinators, Dr. Umayal, Dr. Kavita Bhatti and Dr. Monica, all the esteemed faculty who joined on all the 3 days, Faces of Labor done by Dr. Saraswati, interventions by Dr. Poonam and Dr. Jem Kannan, the AI and EOMICS being done by Dr. Desi Raju and Dr. Pallavi, Dr. Bangal who did the talk on maternal positions in labor, Dr. Karthikeya Bhagat for talk on programmed labor, the panel discussion done by Dr. Poonam and Dr. Sneha Buer, and the panelists Dr. Sushma, Dr. Kiran Chandana, Dr. Farina, and Dr. Shankari. And then the second day, the talk done by Dr. Girija on interventions in labor, intrapartum ultrasound by Dr. Anupama Rao, epidural analgesia by Dr. Preeti Vyas, MSAF and labor done by Dr. Reshmi, VBAC done by Dr. Sumana Drajan, and the very interesting topic of nomenclature in labor by Dr. Chinmayi Ratha. The panel discussion done by Dr. on intrapartum surveillance by Dr. Sureka Taide and Dr. Mitra Saxena. Wonderful panelists, Dr. Lavanya, Dr. Renju, Dr. Swati, and Dr. Vijayalakshmi Sabha. I'd like to thank all of you and the esteemed chairpersons who joined us, Dr. Asha Rao, Dr. Shobha Gudi, Dr. Bharati Mageshwari, Dr. A.G. Radhika, Dr. Sapna Bajaj, Dr. Raki Singh, Dr. Seema Pandey, and Dr. Pratik. And the delegates who have joined on all 3 days, we had a huge number on first day, 570. Second day, it was 490. And today, I think we had around 410. But still, it was a good number. And we're extremely thankful to all of you who joined and gave your valuable feedback. We'll remember all that and we'll make sure that it's done better in the next courses. And we'd also like to thank the tech support given by Neelima, Shreya, and Gauri. Thank you so much for all that help you gave. And I would also like to thank people who have actually given their feedback in the other groups also, because they found the course good enough and that they put it in the groups. Thank you so much for all that. And we leave you with this message. We are hardcore obstetricians and it's time that we update ourselves and keep ourselves abreast of all the latest technology, because we need it to manage our patients, as well as the government, which is coming on quite heavily on us to reduce the maternal mortality. Thank you so much. Now I'll put on the answers so that you can see the answers for the third day. I hope it is visible. It is seen? Monica?
Yes, ma'am.
Okay.
Yes, ma'am. It's seen.
So the first answer is there's no fixed threshold for cervical dilatation in active labor. There's nothing like it has to progress at this minimal rate. And the second answer is the main advantage of the labor care guide compared to the traditional partogram is it focuses on individualized holistic care rather than anything particular, because you need to have a holistic care rather than any rigid thresholds. The criteria used to define near miss in India today is the WHO criteria. The pregnancy-specific obstetric and medical disorders for near miss includes hemorrhage. It is not anemia or embolism. And quality care during labor includes care which is all of the above: evidence-based, client-centric, equitable, and the answers are all three. Providing quality care during labor is likely to result in all of the above: a reduction in cesarean rate, reduction in mortality rate, a reduction in labor analgesia. And under Lakshya, the following are included for provision of quality care in labor in heavy load public facilities, except that is elective cesarean is not included as a provision of quality care. And where is oxytocin synthesized? It is in the hypothalamus. And what is the primary action of oxytocin in stimulating uterine contractions? It is by increasing the intracellular calcium levels. In obese pregnant women compared to normal weight women, which is the following is not correct. The prolongation of latent phase is not there in obese ladies compared to normal weight pregnant women. And then management of acute abruptio, which is not correct. Tocolysis of beta mimetic for steroid cover should not be done to prolong the pregnancy. Immediate delivery is not indicated in a stable mother who's got a preterm fetus. Robson's classification has got 10 groups. Robson's group 10 constitutes all deliveries which are less than 37 weeks, that is a preterm delivery, which is not a contraindication to oxytocin use in labor. All of the above, you can use that. And how should oxytocin be administered in labor? Which should be intravenous. And which of the following is a potential benefit of augmentation in labor? It is shortened labor duration. It is the benefit of augmentation. All except one of the following of contractility agonist, and the answer is progesterone receptor. Intraamniotic pressure beyond which following the onset of true labor pains is it's around 20 millimeters of mercury, and the resting tone during the quiescent stage is 2 to 3 millimeters of mercury. Thank you so much. I think we'll close, Monica.
Can we take the question number 15, ma'am, again?
Yeah, that placenta
there is
previa. Yeah, placenta
Yes,
previa, it should not be taken for placenta previa. It's actually, if it is a low-lying placenta, it's an anterior placenta. You can give a trial of labor, but not for a posterior this thing. And we'll take that answer as right for everybody. We'll take it as right. Whatever you answer, it will be right.
Yes, ma'am. Is there any other question that needs to be clarified from the delegates? Then we can do it. Otherwise, we can conclude the session for the day.
We'll conclude, I think, because it's already 7:20. Yeah. Monica, you can do that.
Thank you, Shamila Madam, and thank you, Parag sir, for the honor to allow me to coordinate the entire day today. I would like to thank all the faculty members and the chairpersons who have joined. And no program can be complete without all the delegates who have joined and who have taken so much of interest in giving us the feedback. Definitely, ma'am, the next masterclass would be on NST, our intrapartum monitoring. And we would be the same team, of course. Thank you so much, everyone, for joining. Yes, ma'am.
The recordings will be available in the ICOG website. Please log in and check, and it will be there probably in the next week. The recordings will be uploaded there, and certificates will be sent to you in the next 15 days. Whoever is joined for all 3 days, you will get it. Thank you so much. Thank you, Monica.
And the certificates will be received on mail. So good night, everyone. Thank you so much for joining us today.
Yeah. Thank you, Monica. Thank you so much.
Thank you. Thank you, ma'am. Thank you so much.
Thank you, Neelima, Gauri, as well as
Neelima, ma'am, Gauri, ma'am.
Thank you,
ma'am. Thank you.
Yeah.
Thank you.
Shall we stop the recording?
Yes.